the chief patron, Dr. Atul Krishna sir, who has always had a profound influence on us and is a source of inspiration. I would like to request Dr. Saurabh Singhal sir to humbly welcome Dr. Atul Krishna sir with a token. Next up, I would like to invite Dr. Sumit Kant Jha sir to honor the very respected Vice Chancellor, Dr. Major General G.K. Thapiyal sir, a gentleman who has made not only the Subharti family but the whole country proud. Sir did his Bachelor of Dental Sciences from KGMC Lucknow, following which he joined the AFMC Pune to do his Masters. Sir went on to join the Indian Army and was awarded the prestigious Sena Medal. Consequently, I would like to call up Dr. Saurabh Singhal sir to formally invite the CEO of Swami Vivekanand Subharti University, Dr. Shailya Raj ma'am, to the occasion. Ensuring this, I would request Dr. Sumit Kant Jha sir to invite the Deputy Medical Superintendent of Chhatrapati Shivaji Subharti Hospital, Dr. Krishna Murthy sir, whose constant motivation and enthusiasm has played a key role in organizing this conference. Following this, I would request Dr. Nishant Vadera sir to persuade Dr. Satyam Khare sir, the Vice Principal of Subharti Medical College and Chairman of this conference, to come up to the dais. Last but not the least, I would like to request Dr. Atul Krishna sir to thank the chief guest of the day, Dr. R.K. Aran sir, for gracing the occasion with his presence. Dr. Rakesh Kumar Aran sir has been a sculptor of human character, a seasonal scholar, and a navigator of knowledge of medicine. Sir has been highly regarded by the physician fraternity of merit. He has been awarded the prestigious Lifetime Achievement Award from API Merit. Next up, I would like to invite Dr. Saurabh Singhal sir, the chief convener, and Dr. Sumit Kanchha sir, the organizing secretary of this conference on Subharti Medicine Updates 2023, to bring forward our patrons, Dr. Atul Krishna sir, Dr. Major G.K. Thapiyal sir, Dr. Shailya Raj ma'am, Dr. Krishna Murthy sir, Dr. Satyam Khare sir, and our chief guest, Dr. R.K. Aaron sir, for our traditional auspicious lamp lighting ceremony. As a tribute to Mother Saraswati, the goddess of knowledge, Mother, may the darkness of ignorance be swept away by the dawn of self-realization. Fourth, Forthcoming is a Saraswati Vandana by the very talented and artistic students of the Bachelor of Performing Arts, who would be paying a tribute to the goddess of knowledge, learning, and purity.
एक बार और अनाउंस कर दीजिएगा, बस एक स्टूडेंट आगे। हाँ बस वो आने वाला है। ठीक है, अभी कर दूँ कि रुको सर? बस वो उसके आते ही कर दीजिए। ठीक है, सेम ड्रेस में होगा।
Forthcoming is a Saraswati Vandana by the very talented and artistic students of the Bachelor of Performing Arts, who would be paying a tribute to the goddess of knowledge, learning, and purity. What a terrific performance, team. You have put your heart and soul in this. May Saraswati Ma bless us with intellect and wisdom. I would now like to request Dr. Atul Krishna sir to say a few words of motivation to stimulate young minds and be our guiding light.
Honorable Vice Chancellor, Major General G.K. Thapalyal, respected Dr. R. Karen sir, my dear Dr. S.P. Sondi, Dr. Tanraj Sirohi, Dr. Sandeep, the Senior Medical Superintendent, Dr. Mina sir, Head of the Department of Medicine, Dr. Saurabh Singhal, Vice Principal of our college, Dr. Satyam Khare, all the faculties of the university, dear friends, and all associated with this program. I wish you a very happy new year and very good health in the coming year and a very long life. And not only long life, but a very healthy long life. On this occasion of the ceremony which we are going to have in the memory of Dr. Mukti on her 67th birthday at this Rani Lakshmi Bai Auditorium. You all know about Dr. Mukti. I have hardly anything to say about her. But just as a formal introduction to Dr. Mukti, I'd like to tell a few things about her. All of you know that she was born in 1957 on this day. She was brought up and educated in Allahabad. She studied at St. Mary's Academy and thereafter in MLN Medical College, Allahabad. She was doing MD course when I got married to her. Then in 1982, she passed her MD examination and she came to Meerut with me. We started our professional career. When she came here, I was already running Chikitsa Niketan, a small clinic at Eastern Kachari Road. After she came, we continued our practice, and she also joined me. Then we started Kamal Nursing Home, and I was a surgeon there, and she was a physician. Then it was realized that there was no ultrasound machine in Meerut. So we started Hans Ultrasound, and she was the ultrasonologist. I think she was the first ultrasonologist of Meerut. She went to England, she took training, then she went to All India Institute of Medical Sciences, she took training there also. And then the first ultrasound machine was installed by us by the name of Hans Ultrasound. And she not only was a physician, but she became so popular with ultrasound that I remember that patients used to come not only from Delhi and adjoining cities, but even from Chandigarh. I remember that some doctors from Chandigarh were sending the patients to Dr. Mukti in Meerut. So she became a very renowned ultrasonologist also. Then we started Lokpriya Hospital. She was the director, and with her help, we started the first multi-specialty hospital of Meerut. Thereafter, she went to England to serve her mother because they were all sisters. She had no brother, and I didn't have my father-in-law. So my mother-in-law was not feeling well. So Dr. Mukti went to Allahabad and she stayed there for about 10 years. Then at that point of time, we resolved that she will earn and our livelihood will be managed by her earnings. And I had a passion of doing some social service. So she said that you go ahead and do the social service. So with my income, I started opening schools and colleges in village areas. Then we created a trust and we decided to open a medical college also. A very important thing that I want to tell you that it was the time when UP had the government run by Behan Mayawati, and I had applied for opening the medical and dental college for the grant of essentiality certificate, and that was denied to us because some huge bribe was asked and I was not in a position to give that. And one point which I want to tell you, because now in future our students who are here, they will be facing such situations. When this huge demand was made to us, I went to Dr. SSL Srivastava, who was our teacher and a very respected teacher. So I took his advice. He asked me only one question. He said that, do you have this money? I said, no. Then he said, how will you give the bribe? So I said that I'll take a loan. Then he gave me an advice, never, because this is the order of the day, that if you want to go ahead, you want to do anything. I'm not saying for Mayawati ji, this is the order of the day. The government may be of anybody, but if you don't cough out a huge money, you are not going to get success. But remember one thing which Dr. S.S. Srivastava told me, I want to tell you that do not give bribe by taking loan. If you have to go ahead, you have to pay some amount to somebody, but do not pay it by taking loan. So I decided not to pay. Now the role of Mukti comes here. So our proposal, our scheme was rejected by that government. She was in Allahabad and I was at Delhi. So we were having a chat on phone. So she said, what happened to your application? I said that it has been rejected. So then what? I said that let us forget about it. Will not open. I'm having good practice. You are running a nursing home in Allahabad and I'm running a nursing home at Meerut. So we are both happy. There's no problem. So he said that I never thought that you are such a person, because when I married you, so the best thing that I found in you was that you are a man of commitment. How can you be so weak that when the Mayawati government has rejected your application and you have surrendered your idea? How can you do it? When I am with you, let us move ahead. We'll find out some ways. So that gave me a lot of strength. Now, I'm telling you that if your wife is saying such words, your strength multiplies like anything. So then I also decided that we'll fight. I ran from here to there. But when you are doing something with good intentions, the nature also helps. And what happened that on 18th of October, just after about a week, when our application was rejected, the government fell. And it was the governor's rule was imposed upon the state. And now the role of Mukti, which I want to tell you, that she said that now you wait and I'll tell you. She managed, she arranged a meeting with the governor. She called me to Allahabad, then myself and her, we went to the governor. And she was so clear in her thought and ideas that she convinced the governor. And the governor said, okay, we'll review your case. Our case was reviewed, and on 13th of March next year, we got the essentiality certificate. It was because of her strength and that we got the certificate. Today, you are sitting in this auditorium, Rani Lakshmi Bai auditorium, which is a part of your medical college. So medical college came because of Dr. Mukti. So I think this is the correct occasion that we should remember her and we should pay our tributes to her, that it was because of her that this medical college came into existence. As far as her qualities are concerned, you all know, she was master of all. You must have heard that I also say to my children, that you should be jack of all, but master of one. And I tell my children to tell their children, and I'm telling you also, that at least you should be master of one, but jack of all. You should be aware of everything. But she was master of all, which is a rare quality. As far as her extracurricular qualities are concerned, she was a wonderful singer, very good dancer, very good performer, very good artist. She gave talks on radio stations and whatnot. Then she was very clear-headed, very good administrator, very strict administrator. She had her views very clearly and she wanted them to be implemented. She never spared anybody. Whether it was me or it was anybody else, what she had in her mind, she wanted that to be implemented. Very rare quality which you will find. Otherwise, people, they budge under the pressure. They are not able to get those things done which they think are proper. You have difference of ideas. But she was the hard taskmaster, very good and strict administrator, but a very kind-hearted person. I have got so many things to say, but I'll tell a couple of things only. Once my driver, not my driver, the working in our institution was posted with her. He came weeping in my room and said that ma'am has done this, and I've been rebuked like anything. And she has said that you get out of this place and I'll see that you are terminated. I could only say that have peace and come to me after a few days. I called him after a couple of days and I said that now you tell me what actually happened. At that point of time, I was surprised to see that he was smiling, laughing. He said, no, sir, nothing. Ma'am is very good. And it was my fault that I had done something wrong and she rebuked me. So after telling that man what wrong he had done and rebuking him like anything, the very next day, she called him, consoled him, and he found out about the welfare of all of his family members and tried to help him as much as possible. So she was very kind-hearted. If she will rebuke one person one day, the next day she'll just console him and she'll take care of the whole family. This is very important. I have seen people that they have got only one quality. Either they are very strict. If you are very strict, naturally the persons under you are likely to break. Being a very kind-hearted person, in addition to being very good administrator, it was her quality. Then I remember she was a very good teacher. She was selected as the best teacher of this university, not only once, several times, and without any partiality, because the voting was used to be done by the students. And not she was not there that they were bound to give vote in her favor. They voted, and she was adjudged as the best teacher of our university several times. She was the best teacher, not only that her teaching skills were wonderful, undoubtedly yes, but she cared for the students in both ways. And she was fearless person. I remember there was one IAS officer posted at Agra, and her daughter was selected in DNB medicine in our college. One day, I got a phone call from that officer, and he said that I want to meet you. I said, well, come on. So he came and said that I want to take away my daughter. Or you set your order right. I said, what happened? He was not knowing that Dr. Mukti was my wife. So he said so many wrong things, bad words about Dr. Mukti, that she rebuked her and this and that, and she did not allow my daughter to go on leave, and every damn thing he said. And he said that, yeah, this is the guy. I said that, who is the guide? So she said that some professor, Dr. Mukti Bhatnagar, is the guide. So I said that you just give me some time. I'll find out and I'll tell you. So I just made him sit in some other room, and I went to Dr. Mukti and I asked that what is this issue with Dr. Manjari. Her name was Dr. Manjari. I think the persons who are in the medicine department, they must be remembering. So she told me that she does not study. She's not giving due attention to studies, always on leave and this, and she thinks that she is daughter of an IS officer, so she can do anything. I am not going to listen anything what you are saying. If they want to take the daughter away, they can very well take it. So I advise that man that she is my wife, I am not in a position to say anything to her. You better go and meet her. So I made him meet Dr. Mukti. Then what to say of Dr. Manjari? That IAS officer, he also came out weeping from her room. And he said that, okay, I'll see, I'll rethink about taking her away. And what happened, that you all know that in DNB, it is very difficult to pass. And that girl cleared her DNB examination in first attempt. So she rebuked her, she was so hard upon her only because she wanted her to study. And she cleared her DNB examination in first round. So now, every year, I get a phone call from that officer, he is retired now, from that IS officer, and he just says one thing, that your wife had been a Devi for me, and she did this, and I can never forget. So this was her quality. I can only say to our teachers, that if we want to give a tribute to Dr. Mukti, then we have to learn her qualities. She will there was no inspection in our college which could be done without her. She'll manage the assessors in such a perfect manner that though the MCI had always been at loggerheads with us, but assessors always went away from here praising not only the infrastructure and the facilities of this medical college, but also the faculties under the guidance of Dr. Mukti. So I'll just say, if we want to give a good tribute to Dr. Mukti, we must learn some qualities from her and try to give them and best to our students. Today, we are having this CME, and I think that we should make it a annual event. Every year we should arrange an event. This time it is very decided in a hurriedly, but from next year I think it should be of national level, and it should be done in such a way that all the participants they get the credit points. So that will be very good. And as far as the management is concerned, management is always with you to help. So you plan in the CME, national level CME every year, and the management is with you. So with these words, I'd like to thank all our guest speakers which have come to deliver speeches. And I'm sure that this CME will be very successful and very fruitful. It will give good exposure to our students, and we all pay our tributes to Dr. Mukti by doing good works. Thank you very much. Jai Hind.
Thank you, sir, for your kind words. I hope many delegates present here would follow your advice and advice of Dr. Mukti Bhatnagar. Next, I would like to invite Dr. R.K. Aran, sir. He would be felicitated by Dr. Atul Krishna, sir. I would now like to invite the CEO of Swami Vivekanand Subharti University, Dr. Shailya Raj ma'am, to propel the thought process of the delegates present in the right direction.
Jai Hind. Honorable Vice Chancellor, sir, honorable speakers of the day, all guests. After what boss has said, there's nothing more. However, on this occasion, actually I don't know what to say because today दिन ऐसा है, मन भारी है, पर I would really want to thank Dr. Saurabh, Dr. Jha and the whole medicine department क्योंकि बहुत short notice पे उन्होंने ये organize किया और it was my mother with all her talents. She was a very staunch academic person. I think she would really appreciate the way department is going on and with all the academic activities which are being held. So I will just congratulate and thank the organizers for having this. I would really thank Dr. Aaron sir, Dr. Sondhi, Dr. Sirohi, and all the speakers for coming here today and taking this academic event forward. मैं मम्मी के बारे में कुछ नहीं कहूँगी because मेरे से जितना और मेरे से ज़्यादा भी बहुत सारे लोग उन्हें जानते हैं. I will just say that she was not a person who would like that उनको दुख में याद किया जाए. She loved life. She lived it to the fullest. She lived life as an independent, strong woman till the end. She used to say a lot of times that हम कभी भी किसी पे dependent होके नहीं जाना चाहते. And this is what happened. I think she believed in God so much, in herself so much, that that is what happened till the end. She was never dependent on anyone till the 7th of June. So we should all celebrate her rather than mourn her, if that is the right word. So we celebrate her in academics, in culturals, in whatever way we can. So I would just request everyone, all her students, all her colleagues, all everybody, her children, to celebrate her in every way we can. एंड कल एक बात डॉक्टर कृष्णा ने कही थी जो मैं आज रिपीट करूंगी, दैट उनकी खुशबू सालों सालों तक रहेगी. और एक बात डॉक्टर संजय पांडे ने कही थी. सो संजय सर की बात, बीइंग अ स्टूडेंट, आई कैन डेफिनेटली रिपीट कि एज अ डॉक्टर शी हैड ऑलवेज सेड दैट अगर कोई पेशेंट हमें कुछ नहीं दे सकता तो अनुभव जरूर दे सकता है. सो एज डॉक्टर्स, बिकॉज टुडे आई थिंक एवरीबडी सिटिंग हियर इज अ डॉक्टर, सो हम अपने पेशेंट से वो अनुभव लें और उनको उसी तरीके से ट्रीट करें लाइक द डॉक्टर शी वाज. So I think that is all that I would like to say in her memory, and be the good children, good doctors that she would want us to be, and take this organization forward as she would want it to be. So just thank you for having this event, taking this organization, her department forward as she would want. And to the organizers again, Jai Hind, thank you.
Thank you, ma'am, for your kind words. A role model, a perfectionist in spirituality, horticulture, arts, medicine, administration, music, and the list goes on. And above and beyond, Dr. Mukti Bhatnagar was an incredible human and a fighter in spirit. We are often taught the concept of life and death. Somewhere at the back of our mind, we try to come to terms with the ultimate reality of life, death. A reality, when encountered, hits you so hard that it leaves you numb. There is not a day that passes where we don't miss you. Not a day when we don't feel the loss of some deep part within us. Thank you, Sang Mata, Dr. Mukti Bhatnagar ma'am, for being the guardian angel of the university and especially the Department of Medicine. Her enthusiasm and wisdom has always been talked of. We are fortunate enough to have a museum dedicated to the noble soul. I consider myself to be privileged to invite everyone present here to the inauguration of Sangmata Museum located at 5th floor of the hospital in Medicine Department. The inauguration would be followed by a breakfast at the department. Subsequently, there would be a visit to the newly inaugurated radiotherapy center led by Dr. Krishnamurthy, sir. So, on behalf of the Department of Medicine, I would cordially invite to all of you to inaugurate the department museum dedicated to Sanghamata Dr. Mukti Bhatnagar ma'am. There we will be having the breakfast also. Then we will gather back here only to proceed with the proceedings of Subharti Medicine update. Thank you. I would request everyone to be back to this auditorium by 10:40 a.m. as we have planned some up-to-date talks to re-equip you with the newer advancements in the world of medicine. Thank you.
जैन सर
अंदर आपने इंटरेक्ट रखा हुआ है। Just doing it on behalf of. Yes, sir. Real artifact.
जैसे ये पेंटिंग बनाती थी सामने देखो हाँ, ये वो उन्होंने ये पढ़ा था, ये कंप्लीट किया ना palmistry she did 3 courses palmistry vastushastra and palmistry vastushastra and one more course.
एक यहाँ ऑडियो वो भी वो हो जाता है उसको प्रेस करके ये जो नरेशन है ना देखिए
Because actually it was not very तो मुझे जब हम खाने में बैठेंगे तो मतलब वापस लेके बी कोर्सेज देखो हाँ उसके बाद सर उन्होंने क्या किया उन्होंने कहा कि हम जो मेडिसिन में पेशेंट्स होते हैं उनकी बाउंस भी करेंगे आई विल रिलेट कि उनको जो बीमारी आती है उससे लोग कहते हैं कि हाँ होता है कि नहीं एंड शी फाउंड यस
They are not telling you anything. But I didn't want any, unpleasantness on any.
There is no other way.
I don't know. Maybe they should
then she found out 70 overpowered that and then she stopped
Sir, लीजिए आप पीछे।
Nagar ma'am. May ma'am bestow her blessings on all of us. With hearts full of emotions and eyes full of aspiration, we begin today's talks. I would like to invite Dr. Sumit Kant Jha sir to introduce the first panel of chairpersons and speakers for a talk on vasculitis syndrome. Over to you, sir.
A very good morning to all the dignitaries. We will begin our day with a topic which is often left untouched, both during the post-graduation and our clinical practices. Though a good bulk of patients, if evaluated properly, will give a definite clues about these untouched aspects of internal medicine. To know more and more about less and less, we need really good experts, a team of experts to guide us. So, first of all, I would like to call one of the veterans of internal medicine on the stage as the first chairperson of the talk, Dr. R.K. Adams, sir. Sir has done his MBBS from LLR Medical College in 1971, very senior person, sir, and MD from LLRM as well. He was the organizing chairman of the RSSI UPCon 2019 at Meerut. He was the president of IMA Meerut branch from 2008 to 2009, and he has received different awards like Meerut Veteran Award in 1999, Lifetime Achievement Award from API Meerut in 2014, Lifetime Achievement Award from IIM Meerut in 2016, and Health Icon Award from Times Group in 2018. We welcome you, sir. Now I'd like to invite another legend to the stage. We Subhartians are fortunate enough that sir still gives time from his busy schedule to our UG and PG students. Dr. S.P. Soni, sir. Sir has done MBBS from LLRM from 1975 and MD from LLRM in 1980. He has got vast teaching experience. He has got number of journals to his name. And the big achievements are he was the course coordinator for the last 6 sessions of the certified course on diabetes run by PHFI and Mohan Diabetes Research Foundation. He was the investigator in a multicentric Remox trial aiming to decrease the duration of anti-tubercular treatment published in NEJM. He conducted a study on primary drug resistance in pulmonary tuberculosis published in Indian Medical Gazette in October 2010. He is the recipient of Rotary Vocational Excellence Award 1999. He was awarded Meerut Ratan in year 2003 and he was the president of Meerut chapter of Indian Critical Care Society for 4 years. Welcome, Soni sir. And the next guest knows no introduction in Subharti at least. Shefali ma'am. She was attached with us for more than a decade in different levels, and she has played a vital role in developing the Department of Medicine for both the UG and PG level in association with our ma'am, Dr. Mukti Bhatnagar ma'am. So please welcome Shefali ma'am to the stage. And finally, I would like to invite SP Soni sir to introduce our speaker, Grover sir.
So, good morning, friends. It's my honor and privilege to introduce Dr. Sandeep Grover. When I look at the medical fraternity, there are 3 kinds of people. 1, who are practitioners. 2, who are academicians. And 3, who are good teachers. So if you combine all these properties into one, this is what Sandeep Grover is. He's a product of our own alma mater, where I studied, Dr. Aaron studied, and Dr. Atul studied. LLRM Medical College. And then subsequently he did his DM Immunology from Sanjay Gandhi PGI. He has also been a Rheumatology Fellowship 2006 from Glasgow. So I think I will not stand between him and you, and I'll invite Dr. Sandeep to please start his deliberation. Dr. Sandeep, please.
Thank you, Dr. Sundi sir, for these generous words. I am truly honored, and I'll try to live up to those ideals in my life, I assure you. Thank you so much, and thank you so much, organizers, for inviting me for this, I would say, a great occasion, because Dr. Mukti was so dear to all of us. I was also associated with this department for a long period of time, and I fondly remember my association with ma'am. And one thing I remember about her was that she was a true academician at heart. She would always value words of wisdom, and would always find out positives in every person and identify that person with those positive qualities. So with these words, I start on this talk which has been given to me. It's vasculitis. So vasculitis in itself is a huge topic. Just to tell you that my colleague, Professor Aman Sharma, who is the HOD Rheumatology at PGI Chandigarh, has just authored a very thick book called A Textbook of Vasculitis. So a topic which needs a book of 1000 pages is practically impossible to cover in a very short span of 20 to 30 minutes. So I will give you a snapshot of vasculitis, what vasculitis is. And as I can see that my audience has very young people from their UG students, and it would be a challenge for me if I can give them a concept of this rare but intimidating illness, which is like a hydra having many heads and very difficult to fathom and maybe diagnose and treat also. So vasculitis, literal meaning of vasculitis is inflammation of blood vessels. So to be more specific, it is inflammation of the wall of blood vessels. So what does it do? Our body is made up of a network of blood vessels. The left side of the heart sends out oxygenated blood, which goes through the arteries, which are large sized arteries, which further give rise to medium sized arteries, and then they give rise to small sized arteries and arterioles, and up to this level they have got a thick elastic muscular wall. Ultimately, these arterioles give rise to capillary network, and this capillary network is the site of oxygen and carbon dioxide exchange inside the tissues, ensuring that they get enough oxygen, and then the deoxygenated blood is carried by venules to the small and ultimately larger veins to the right side of heart. Now, inflammation of this network at various levels gives rise to the syndrome of vasculitis. So this is the key slide for vasculitis. First and foremost, you remember that vasculitis is inflammation, and it's different from a concept called vasculopathy. So if you have a disease so for example, an acute myocardial infarction because of a ruptured plaque is a vasculopathy, but not a vasculitis. The plaque gets ruptured, there is a change in the surface of the blood vessel, the platelets get activated, a clot happens, and the area supplied by that artery infarcts. The same thing, this is MI. But if something happens to the blood vessel wall due to inflammation, and that inflammation denatures the vessel wall, giving rise to partial or complete thrombosis, this leads to manifestations of vasculitis. So most of the vasculitis have systemic features because it is a systemic inflammatory disease. So fever, arthralgia, weight loss are common issues in many vasculitis. But this is what gives rise to the syndrome of vasculitis. So you can very well imagine if a large blood vessel is involved, supposedly a right radial artery is involved or a right brachial artery is involved. So that would give rise to manifestations pertaining to the area it supplies. So a large vessel supplies a large area, so the symptoms are over a large area. So you can have limb claudication, you can have differential blood pressure in both the arms, like in Takayasu arthritis, you can have absence of pulses, you can have aortic dilatation, you can have bruise, you can have constitutional symptoms because bigger blood vessels are involved, so more constitutional symptoms are there. When medium-sized vessels are involved, then you can get ulcers which are very deep, and you can have subcutaneous nodules. You can have a mesh-like appearance of the limbs, which is called livedo reticularis. You can have digital gangrene. You can have mononeuropathy. If you have multiple mononeuropathy, then it is called mononeuritis multiplex. You can have aneurysms, and you can have hypertension of renal arteries involved. When small sized vessels, the capillaries are involved, the area supplied by capillary is very small. So if capillaries of the skin are involved, you get purpura. You can have urticaria, you can have superficial ulcers, you can have splinter hemorrhages, जैसे आपको infected endocarditis में पढ़ाया जाता है, इसमें भी मिलते हैं. You can have scleritis, episcleritis, uveitis. You can have glomerulonephritis. Kidney is a bunch of nephrons. Nephrons are made by capillaries. So if capillaries are involved, the kidneys get involved, leading to glomerulonephritis, and that's why kidney involvement is so important in patients of vasculitis. You can have mesenteric circulatory involvement, which leads to abdominal symptoms. You can have pulmonary capillary involvement, which leads to pulmonary hemorrhage, cavities, and of course, constitutional symptoms are common to all three categories. So this is how vasculitises are classified. If you have only capillary or predominantly capillary involvement, you can have cutaneous vasculitis. If you have capillaries with arteriolar involvement, then you have a disease like hinox-noline purpura or cryoglobulinemic vasculitis. I guess HSP, most of the students have studied in pediatrics. So we'll touch on that. Then you have capillary plus small size involvement with variable involvement of medium size. So then there the ANCA-associated vasculitis come into the picture. We will touch on that also. If you have medium to small vessel involvement, you have diseases like polyarteritis nodosa and Kawasaki disease. And when you have predominantly large vessel involvement, then diseases are mainly giant cell arteritis and Takayasu arteritis. There are some diseases which don't respect these boundaries at all. They can affect any blood vessel, be it arterial, artery, veins, capillary, and one of these diseases, fortunately not very common in our country, is Behçet's disease. So this is the basis of classification of vasculitis based on vessel size. But the Chapel Hill Consensus Conference also subdivided them into according to the etiology. So if you have large vessel vasculitis, I just told you Takayasu and giant cell. Medium vessel vasculitis is polyarteritis nodosa and Kawasaki disease. But small vessel vasculitis can be either ANCA associated, which has three categories: microscopic polyangiitis, GPA, which was earlier known as Wegener's granulomatosis, eosinophilic granulomatosis polyangiitis, which was earlier known as Church-Strauss syndrome. So these ANCA-associated vasculitis are posse-immune. That means if you look at a biopsy of these vasculitis, suppose you do a kidney biopsy on this and you do an immunofluorescence, you will find that there are no immune complexes. But there are certain immune complex mediated disease where there will be immune complexes present on the biopsy. So a few of these are anti-GBM disease, which was earlier known as Goodpasture syndrome, cryoglobulinemic vasculitis, IJ vasculitis, which was earlier known as hinox-noline purpura, and hypocomplementic urticarial vasculitis. Variable vessel vasculitis, I just told that any blood vessel can be involved, namely Behçet's disease. Vasculitis can affect single organs, so there is renal limited ANCA-associated vasculitis, skin, cutaneous vasculitis, and so on. Vasculitis can be a complication of pre-existing connective tissue disease. They are not primary vasculitis, so vasculitis can affect lupus, rheumatoid, sarcoidosis, and so on. Infections are a very important cause of vasculitis, so it is always important to rule out infections in many patients of vasculitis. So hepatitis C causes cryoglobulinemia, hepatitis B causes PAN, syphilis, fortunately very rare now. Drugs, very important source of vasculitis. A drug like propylthiouracil or montelukast, which are so commonly used in medicine OPDs, can actually cause ANCA positivity and vasculitis. Of course, malignancy, paraneoplastic vasculitis is also there. So it is a huge list. I will try to give you a snapshot by covering these three categories: Takayasu, PAN, and ANCA-associated vasculitis. So we will try and rush through because these are huge topics, and maybe I can make it interesting if you can diagnose at least one patient in your OPD in the next few months. So ANCA-associated vasculitis are usually clubbed together. These are three different diseases with many differences, but they are classified under single category. So these are namely GPA, which was earlier known as Wegener's granulomatosis, microscopic polyangiitis, and Church-Strauss syndrome, which is now known as eosinophilic granulomatosis with polyangiitis. So they are considered together because of certain shared features. First is they preferentially involve small vessels. So all of them can have purpura. That means they involve the arterioles, capillaries, and venules. Secondly, they're glomerular lesions. The pattern of renal involvement is similar in all these three. So they can cause crescentic or proximmune glomerulonephritis. These three in itself can present as a pulmonary renal syndrome. So in the ICU, you have a patient who has lung infiltrates, respiratory failure, which is ultimately diagnosed as pulmonary hemorrhage with deranged renal function and an active urine sediment. So this you could be dealing with this. Most of these cases have some evidence of ANCA positivity, and the treatment protocols for them are also similar. So they are clubbed together. So when you look at them, so these are three different categories with some overlapping features: GPA or Wegener's, MP, and Church-Strauss. So microscopic polyangiitis causes lung involvement, glomerulonephritis, neuropathy. Church-Strauss happens on a long-standing background of bronchial asthma, usually have hypereosinophilia. So any patient who has a long-standing history of bronchial asthma now presents to you with either PUO with persistently high inflammatory markers, leukocytosis, has developed pulmonary infiltrates, myocarditis, or neuropathy, or some renal involvement, or some skin involvement. You should actually think of this thing as a possibility. Wegener's, which is the most dreaded of these three. So Wegener's can cause granulomatous inflammation involving the respiratory tract and necrotizing vasculitis affecting small and medium vessels. So Wegener's is a heterogeneous disease. It has got two types of involvement. One is vasculitis, true vasculitis, where it causes small vessel involvement. So patients can have purpura, they can have neuropathy, they can have renal involvement as a manifestation of vasculitis, but it also has a granulomatous component. So it looks like a granuloma on biopsy, and this granulomatous inflammation preferentially involves the head and neck. So it can cause sinusitis, a tracheal involvement which can lead to subglottic stenosis, pulmonary nodules which keep coming and going. It can involve the orbit, it can involve the ENT involvement, ear, nose, throat, eighth nerve involvement, and multiple cranial nerve involvements. So Wegener's is a heterogeneous disease. So ANCA, which was first described in 1982 in a patient with glomerulonephritis, has had a remarkable journey over the last 30-40 years till 2017, where a revised consensus was made on ANCA testing. And this is something which has been a matter of debate. So ANCAs were originally described based on their appearance on immunofluorescence. And this is the type of appearance you have. So how is it done? The patients, so ANCA attaches to the patient's neutrophils. So what you do, you take the serum of the patient, plate it on a slide, and neutrophils, there is a neutrophil coated slide which is plated with the patient's serum, and then you try and look at it into the immunofluorescence microscope. So if the granular staining of cytoplasm is there, this is called the C-ANCA pattern. And if it is a perinuclear pattern, then it is called a P-ANCA pattern. So I'm trying to simplify it here, because you should have to understand that this means that the making of this neutrophil coated slide has to be standardized. These neutrophils are fixed in alcohol, and this procedure involves very fine dilutions. Then it can go wrong also. So you need a lot of expertise in the lab to run this test, and ultimately the test interpretation is observer dependent. So that means if the observer is well trained and experienced, they are more likely to make an accurate diagnosis, and if the procedure, and make sure that the procedure has been done correctly. So to avoid this issue, people tried to find out what are the antigens targeted by these ANCA antibodies. So what they realized, what the antigens responsible for these patterns were as follows: that the C-ANCA, the antigen is proteinase 3, and for the P-ANCA, the antigen is myeloperoxidase. But there are multiple other antigens also. So PR3 is more responsible for C-ANCA. So anti-PR3 antibody is responsible for the C-ANCA pattern. But there are other antigens which can also cause C-ANCA positivity. And in P-ANCA antibody, MPO myeloperoxidase is only one of the many antigens which can cause the P-ANCA positivity. So here the relation is not as good as with C-ANCA pattern. So it was decided to do away with ANCA testing by immunofluorescence, but some people would say that you are missing something, because if only P-ANCA testing is done by ELISA or something, you look only for specific test, you may miss the other antigens also. So that's why these approaches have been considered for ANCA testing. So the ideal approach is to test every patient who have a clinical picture suggestive of ANCA-associated vasculitis. You do immunofluorescence as well as the ELISA and classify them further as having either both negative or both positive or a combination of these. But this is not cost effective, it's quite expensive, and it really doesn't change the treatment. Because ultimately, even if you have both the tests negative and you are fairly sure that the patient is having vasculitis, you will still have to treat it. So the recommended approach was, which is being used by certain labs, commercial labs, is what they do is that they do a screening by immunofluorescence, and based on the immunofluorescence pattern, they do a corresponding ELISA for that antigen. So you test a sample, if it is C-ANCA positive, you do an ELISA by anti-PR3. And if it is P-ANCA positive, you do an ELISA by the anti-MPO antibody. Again, this is also fraught with certain issues, because there may be patients who may be P-ANCA positive, but the MPO may be negative and the patient may still be clinically having vasculitis. So a study was done and a group of experts agreed together and they did a gating strategy that only patients who have a issue that they look like ANCA-associated vasculitis should we just do an ELISA straight away. And if you find positivity on ELISA, you stop there. If you don't find an ELISA, then repeat the ELISA or do an IF subsequently. So these are three different approaches, and all three approaches are being used in various parts of the world. A recommended approach does not mean that everyone has agreed on that. In Merit, what we do is that we do an IFA, and if it is positive, we do a ELISA after that. That is the usual approach we use. The problem is that it is cannot poorly standardized test, and if your patient selection is not proper. For example, if a patient has a clear-cut evidence of SLE and you still do an ANCA testing, a P-ANCA would still come positive because of the ANA positivity. So you won't get anything out of that apart from just creating confusion. So the pre-test probability, identifying the patient, making a clinical diagnosis, and now this is called Bayes theorem. If any statisticians are here, they can explain it to you, that if you have a good pre-test probability, only go for that test. Twitter पे मैंने कुछ दिन पहले पढ़ा था, and it's a very good line. If you don't know what to do with the test, if it comes either positive or negative, don't do it. So if it really doesn't add up to it. Okay, so ये patient के resources आपके हाथ में है, आपको decide करना है आप उसे कैसे spend करते हो, और ये जितनी जल्दी आप सीख लो रेजिडेंसी में, उतना आपको जिंदगी में काम आएगा. So ANCA can be positive in diseases other than vasculitis also. So 20% of ANA positive patients can have ANCA positivity. ANA positivity is seen in SLE, Sjogren's, systemic sclerosis, IgG4 disease. They can also be P-ANCA positivities reported in inflammatory bowel disease. Also, it can be seen in liver diseases. And very importantly, infections can be a source of ANCA. Bacterial infections. Amoebiasis is one causes, which is often overlooked. It was a question in my DM exam. Invasive amoebiasis can cause C-ANCA positivity. Malignancy, it can cause everything. HIV, it can cause everything. Every time antibody can be positive in a patient of HIV or in a patient with a paraneoplastic syndrome. Drugs, very important. Montelukast, propylthiouracil, two notorious drugs which can cause ANCA positivity. Even vasculitis can develop as a consequence of these drugs, and it just disappears after the discontinuation of the drug. No specific treatment is needed. And there are patients who are asymptomatically positive. So Wegner described this condition for the first time. It was described by a German, Heinz Klinger, but Dr. Wegner was pioneer. He reported on a series of such patients, and ultimately Americans took it forward for a heterogeneous disease which can cause right from ulcerations in the oral mucosa 2 orbital enlargement, conjunctivitis, pseudotumors, sinusitis, a subtle nose deformity, pulmonary involvement in the form of cavities, bleeds, skin nodules, glomerulonephritis, positive ANCAs, to multi-system involvement inside the body. The classic triad for Wegener's is always upper airway involvement, lower respiratory involvement, and kidneys, but it can be a combination of either of the three, leading to a limited Wegener involvement. So Wegener's limited to just head and neck without involving the throat, the lungs, or the kidneys is usually classified as a limited Wegener's and involves a different treatment strategy as opposed to a systemic involvement. So I'll rush through this. This is a very important slide. It is one of the causes for saddle nose deformity. Undergraduates, please note, when you go through your ENT rotation, you will learn that saddle nose deformity can be either due to bony involvement or due to cartilaginous involvement. So this is one cause where the cartilage is involved. There are other causes like relapsing polychondritis, which can have an overlap with Wegener's, and there is the disease called syphilis, which is fortunately not seen by our generation. Hopefully, you also don't see it by our Dr. Sondhi might have seen such cases in the past. So this is a lateral view of the neck, and this patient has a squeaky voice. Anybody can point out something in this? Okay, I'll make it easy. So this patient has got a subglottic stenosis. Now this patient who has got a subglottic stenosis is living on a knife's edge. Can anybody tell me why? Even if they develop a small viral infection, which are so rampant these days, it can cause mucosal edema to an extent that these patients develop a stridor and end up in a severe respiratory failure, which is potentially life-threatening. These patients require tracheal surgery and they carry tracheostomies for years. So treating Wegener's in time is important to ultimately avoid such type of long-term complications. This is a CT head of such a patient who has got a huge granuloma inside the nasal cavity. This was the condition which was originally known as a midline granuloma. आपने ENT की books में पढ़ा होगा. Ultimately, ये सब patients vasculitis माने गए हैं. And this patient also has sinusitis, maxillary sinusitis. Pulmonary manifestations are so important. Wegener's can have pulmonary infiltrates, which can be nodular, which will be fleeting, coming and going. These patients can have cough, hemoptysis, pleuritis. Sometimes it is a silent pulmonary involvement. Patient doesn't have any symptoms. Only radiological abnormalities are found. So every patient whom you suspect of Wegener's, at least do an X-ray. That is the least you can do of the sinuses, paranasal sinuses, and the X-ray of the chest. And if something is fishy, go for a chest CT. So look at this picture. These patients have features which look like secondaries. A repeat X-ray 2 weeks or 3 weeks later, you find that the lesions have just gone away on their own. So Wegener's can happen like this. A few of these lesions can become thin-walled cavities, fluid-filled thin-walled cavities, and patient is not as sick. You think it might be TB, but how can TB be so easily become bilateral and still the patients are not that sick? So these are common abnormalities found in Wegener's, and this is a dreaded complication. Some of these patients present with acute respiratory failure. You find that the hemoglobin has dropped by 2 to 3 grams in a matter of hours, and these type of infiltrates you find on the X-ray as well as the CT, and your colleague does a bronchoscopy, and the returning aliquots show a lot of blood, and you diagnose these patients as diffuse alveolar hemorrhage. This is one indication where a plasma exchange might be needed in patients of Wegener's granulomatosis to save their lives. Fortunately, many of these patients respond to hydrosteroids also. Kidney. Every patient of Wegener's is at risk of renal involvement. 1/5 of these patients have evidence of renal involvement at presentation. And ultimately, 2/3 of these patients will develop some kind of renal involvement over a course of their illness. And here we mean over a course of untreated illness, because treatment can actually prevent development of renal involvement. Patients who appear to have limited Wegener's will ultimately develop glomerulonephritis. So you need to monitor the renal status as well as the urine examination at all visits. What is important is that this can lead to chronic kidney disease. So many of these patients will develop chronic kidney disease. They may need renal replacement therapy in the form of dialysis or transplant in future. So if you diagnose and treat such patients on time, you can actually prevent preventable complication, which can be a huge burden on the society, on the family, and as well as on the patient. So it is important. So diagnosis is so important because this is a tragedy. Kidney biopsy shows fibrinoid necrosis, crescents, and infiltration by neutrophils in an ANCA positive patient. Ocular manifestations. These are very important. Wegener's can present as scleritis, a scleral melt. You can see in these patients there are so many findings. There is a nerve palsy. Patient is having a squint. They have an ulceration right at the canthus of the eyes. There is a communicating fistula over the lacrimal gland which has been inflamed, and there is a saddle nose deformity. So Wegener's can have, this is the most severe case you can have, but there are certain cases which are much more indolent, nevertheless have the disease. I used to have a patient who used to have a white discharge from her lacrimal gland every few days. She used to take a course of antibiotics and it would improve only to come back. And that diagnosis, and we could diagnose her as having Wegener's granulomatosis because she never knew that she had lost her hearing in one of her ears till an ENT examination was done. She was carrying an 8th nerve palsy for years and she was having this lacrimal gland involvement. So she was having a limited Wegener's involving just the head and neck, and she responded to a maintenance therapy of azathioprine and became totally asymptomatic. However, the 8th nerve function could not be restored. So this is how a day-to-day practice you can find such patients. Not every patient will land up in the ICU. Skin is very important. These patients can have purpura, they can have subcutaneous nodules, shallow ulcers, and sometimes dermal infarcts due to the involvement. Wegener's can present with inflammatory arthritis, which may very much look like rheumatoid arthritis, and almost half of these patients have positive rheumatoid factor also. So this may be the clinical presentation. We have seen a couple of patients who presented to us with RA-like picture with seropositivity, treated with methotrexate, doing well, and then one day presenting with diffuse alveolar hemorrhage. That can be a nightmare. And you can never predict it. Not every RA patients need to be tested for ANCA unless and until you have such features to suggest that. Wegener's has neurological manifestations, most commonly is asymptomatic or symptomatic, multi or mono neuropathy. Mononeuritis multiplex or confluent mononeuritis multiplex presenting as a distal asymmetric polyneuropathy can also be seen. Cranial neuropathy can occur in up to 1/10 of these patients. Rarely these patients can present with CVA, but fortunately, I am yet to see such patients. These patients can have meningeal involvement also, again, a very rare manifestation. Dr. Arun might have seen such patients. तो Wegener's is the बड़ा भाई of ANCA-associated vasculitis. इसके दो छोटे भाई हैं, एक microscopic polyangiitis, देखने में Wegener's जैसा है, skin involvement में purpura, with rapidly progressive glomerulonephritis, and less commonly, but very ferociously, the lungs can be involved in the form of alveolar hemorrhage. Ultimately, these patients can also progress to ILD. So in the past, patient has had alveolar hemorrhage, now they have recovered and the lungs are now fibrosed. This could be one condition which could have happened at that time. As opposed to Wegener's, which has got a long history of relapses and remissions. Fortunately, this disease is usually monophasic. Happens once, very unlikely to relapse if treated adequately. इसका एक और छोटा भाई है, which is Church-Strauss syndrome, as I told you, in a background of allergic illnesses, most commonly bronchial asthma, followed by nasal, followed by allergic rhinitis. Such patients develop systemic inflammatory features with high CRP and such systemic features like a skin rash, kidney involvement, neuropathy, or you have developing joint pains with evidence of, this is the most common presentation, that these patients now develop glucocytosis. 20,000 का TLC आ रहा है, हाई CRP है, कोई कॉज नहीं मिल रहा, बार-बार एंटीबायोटिक्स चल रहे हैं, बार-बार एडमिट हो रहे हैं. That is the time we actually suspect such patients. So these patients are Church-Strauss syndrome. So this is a biopsy from such a patient showing eosinophilic infiltrates. So the key finding is eosinophilia in these patients. You have such presentation, you have eosinophilia in the peripheral blood film. Think about Church-Strauss syndrome. ANCA-associated vasculitis treatment is protocol based. You have confidently diagnosed a patient, you need to assess the disease. Assess whether major organs are involved. If kidney is involved, lung is involved, nerves are involved, it is a major organ involvement. Any organ which is organ or life threatening is major organ involvement. So like malignancy, you need to induce remission. So blast the disease at the onset, which can be done with either glucocorticoids with cyclophosphamide or glucocorticoids with rituximab. Now, rituximab is placed at an equal pedestal like with cyclophosphamide and as these conditions. If you don't have enough time for these drugs to act, for example, patient has diffuse alveolar hemorrhage or the glomerulonephritis is rapidly progressive, creatinine is doubling in every 2 days, then you need to do a plasma exchange in such patients. If your assessment shows that major organs are not involved, for example, patient just has perforated nasal septum with scleritis of the right eye, then you can consider methotrexate, MMF, and azathioprine in place of cyclophosphamide, which has got its own issues. If you have achieved disease control and after 6 months disease is in remission, that means inflammatory parameters are controlled, evidence of organ involvement has subsided, then you need to maintain these patients. Maintenance can be either with azathioprine or methotrexate and with tapering of glucocorticoids, but this is better, easier said than done, can be very tricky also. Or you can continue to give rituximab frequently in lesser doses with monitoring of B cell levels and immunoglobulin levels, and in a few cases the treatment can even be stopped. So this is the person to person and patient to patient perspective, why to do it and when to do it. This is basically fine tuning of treatment. Its another cousin is polyarteritis nodosa. Polyarteritis nodosa is important. It was described by Kusumol. So Kusumol was a legendary physician. We all have learned about Kusumol sign, Kusumol breathing, and so on. So Kusumol described these findings in the patient who was having a PO where no cause could be found. Ultimately, the patient died, and the autopsy showed nodular swellings in the coronary arteries. So this was the original drawing from the autopsy by Kusumol. So one glimpse of the transected muscle immediately demonstrated something unusual, namely numerous whitish small tumors up to the size of poppy seeds and hemp seeds inside the coronary arteries. So coronary artery involvement was there due to PAN. So they actually named it periarteritis nodosa. Kusumol and Mayer, both legendary physicians, they gave it the name periarteritis nodosa, which was ultimately modified to a name of polyarteritis nodosa. So PAN, हम जब स्टूडेंट्स थे और पीजी एंट्रेंस की तैयारी कर रहे थे तो हमेशा कंफ्यूज होते थे कि पी एंका किसके लिए और सी एंका किसके लिए है. तो भाई माइक्रोस्कोपिक पॉलीएंजाइटिस के लिए पी एंका है, लेकिन पैन के लिए पी एंका नहीं है. These are ANCA negative vasculitis. It involves preferentially medium and sometimes small vessel involvement. So it does not involve the veins. So medium muscular arteries are involved, and that's why its manifestations में purpura unusual है. Small vessel involvement नहीं है. So kidney involvement इसलिए होता है because there is arcuate artery involvement. So you may find aneurysms inside the arcuate arteries which are medium vessel. So there is non-glomerular kidney involvement. So urine sediment will be bland. Patient will be having hypertension. Creatinine derangement won't be as much as you see in a glomerulonephritis, and there will be systemic features. Most commonly mononeuritis multiplex, fever, joint pains, and cutaneous ulcers. The most common presentation I see in my practice. Sometimes these patients have GI involvement, there is mesenteric vessel involvement, and they have frequently abdominal colic. You can also call it abdominal angina. The moment they take food, they have pain, and that's why because of the compromised vascular circulation. They can present with malabsorption. Sometimes I have seen patients get references from Dr. Rajesh Kapoor, has operated on celiac artery aneurysm, and so on. And these patients, ultimately, after a successful surgery, we have managed to treat them with minimum suppression and halt the disease. PAN can be either systemic or just limited to the lower limbs, skin, which may be just cutaneous PAN. PAN has been found to be associated with active hepatitis B infection. So all of these patients need to be screened for hepatitis B. It most commonly affects males after the age of 50. And you have livedo reticularis, you can have ulcers, you can have subcutaneous nodules, you can have gangrene, and as highlighted by Kusumol himself, you can have coronary artery involvement. So again, it's so easy to read about this. Imagine you're seeing a patient who has just been operated for a celiac artery aneurysm. He gives a complaint of off and on fever, and his TMT is positive. To diagnose PAN in such a patient can be very tricky because vasculitis, things really don't end up. Treatment of PAN, non-severe disease, you just give methotrexate or azathioprine with steroids. That means major organs are not involved. Just cutaneous PAN is there, just skin ulcerations are there. It's very difficult to get these patients off steroid. I can vouch from personal experience. I've seen patients, big VIPs, taking 5 to 10 milligram of prednisolone for years, because the moment they try to stop it or taper it off, it just comes back. But if it is a severe disease, then recommended induction is with cyclophosphamide. I can vouch from personal experience, nothing else works. Even rituximab has not worked as well in PAN as it has worked for ANCA-associated vasculitis. So these patients need to be induced by 6 to 8 doses of cyclophosphamide in a dose of 15 milligram per kilogram. And if you are lucky, you will induce a remission, then you can maintain them as a non-severe disease with azathioprine. So this is one aspect of PAN which can be very disheartening. Sometimes this treatment fails and these patients actually are left for themselves. The last category of illness which I wanted to discuss here was Takayasu arthritis. It was common because it is a very fascinating disease for young residents of medicine in their OPD when they find that a patient has got an absent pulse. इस हाथ में तो पल्स ही नहीं मिल रही, ऊपर की पल्स भी गायब है. And that is where the whole enigma starts. This was described by Japanese people for the first time. Yamamoto described it in 1830. But Takayasu actually did the whole work and he described it after he found an AV malformation and aneurysms in the retina of a patient. And then went on to look for this and found that there are so many patients who have this. So I can tell you, Japan and India are two countries who have the maximum cases of Takayasu arthritis. And we have certain differences in our patient populations also. Takayasu arthritis is a large vessel vasculitis. So large vessel means the biggest vessel is aorta. And this involves the aorta and its large branches, causing thickening and fibrosis of this vessel wall, which causes luminal narrowing, leading to either a complete obstruction of the vessel or sometimes aneurysmal formation. It is since the blood vessel involved are huge, the surface area of those blood vessels are included, so the extent of inflammation is also very high. So these patients present with so many constitutional symptoms: fever, weight loss, myalgia, arthralgia, with no cause in sight. It is most in our country, it is most commonly seen in young women less than 40 years of age. So you need to remember this as one of the reasons for a pulseless disease. For medicine residents, if you find an absent pulse in the right upper limb, what are the other causes? You need to look for thoracic outlet syndrome. You can lead to thoracic outlet syndrome के बहुत सारे causes होते हैं, इसमें से एक cause cervical rib भी होता है. So ये सब आपको पता होना चाहिए. जब आप इन सबको rule out कर लेते हैं, only then you can think about this, because it will need a lot of imaging to assess the extent of disease. So it is a chronic idiopathic granulomatous large vessel vasculitis. It can lead to either segmental stenosis, which leads to occlusion of the vessel, or it may be after the inflammation, the vascular bed, the muscular wall is not as strong as it was, so it leads to aneurysmal formation also. In our country, males are less commonly affected, mostly females are affected, and as opposed to Japanese patients. Okay. So I would say there are 3 stages of Takayasu arthritis. In the phase 1, you just have a systemic or a pre-pulseless stage. If the patient presents to you in this stage, they just have constitutional symptoms like low-grade fever, malaise, night sweats, and they are frequently actually given ATT based on these symptoms. And in some patients, ATT has been found to work also. So that has led to another area of research, where because there is granuloma formation, they have tuberculosis-like symptoms, and many of these patients respond to tuberculosis. They might be having a TST positivity. So people have looked at that angle also. In our country, where tuberculosis has been so prevalent, is there a relation between the high tuberculosis rates and high evidence of Takayasu in our country? Till date, the link is not very clear, but it is customary that such patients have been given ATT and a few have responded also. But this is actually a difficult stage to make a diagnosis. Then comes the vasculitic stage, where constitutional symptoms accompanied by vascular involvement with evidence of tenderness and pain. So if this patient has a carotid artery tenderness or a audible bruit over the carotid artery, for you, that is a sign in nobody to look for. So always palpate the carotid artery. The phase 3 stage is the common stage of presentation. Fibrosis of the vessel wall has happened, aneurysmal formation, occlusion, pulselessness is there. It is believed that this disease is burnt out at that time, but this is not entirely true. We are dealing with a huge vascular area which is still inflamed may not have the burnt out complications like fibrosis. So I can vouch from my personal experience, and the literature also tells that it is a disease of a lifelong inflammation, which may be stuttering, which may have spurts where it goes up and down. So you need to be actually vigilant, because there are no proven strategies of treatment where you can actually fully control the disease. So it's like treating rheumatoid arthritis, where you can have frequent relapses and remissions, and your treatment goes up and down. You sometimes need to give more of steroids, sometimes you need to give more of uh, non-steroidal drugs to control it. Very importantly, this disease, if you look at the angiographic classification, this gives you an idea how different presentations happen. Sometimes it affects only the branches of the aortic arch, which is class 1. Sometimes it starts from the aortic valve involvement itself. The aortic arch and its branches are involved. Sometimes this inflammation happens right in the thoracic aorta also, apart from this. Sometimes it goes down, only affecting the descending aorta and the renal artery involvement. Sometimes only the renal artery is involved. Sometimes the whole aorta is involved. Depending on the area involvement, you can have different vascular and clinical features. So every patient in whom you suspect Takayasu arthritis, you need to actually do a conventional angiography on them. Only then you can know the true extent of disease. Research has shown that doing a high resolution magnetic resonance angiography can be a good substitute for a conventional angiography to map the extent of disease. Then looking at MR spectroscopy, which can give idea of the inflammation and to plan treatment, but that is for specialized centers only. PET-CT has also evolved as a possible imaging modality. PET-CT based angiography, if you can do, then you can have areas, hotspots where inflammation is happening, and accordingly you can plan treatment. So treatment of the Euler algorithm, I guess it's not very clear here. So you need to start with a high dose glucocorticoid therapy, 40 to 60 milligrams per day, give it for 4 to 6 weeks, then taper, and then start using steroid sparing drugs. In our country, we use methotrexate a lot, but recent research has focused on the use of tocilizumab as a possible alternative, which has remarkably led to a decrease in steroid dependence in such patients. Last slide is about cryoglobulinemia. It is very relevant to this part of the year. In cold seasons, you get patients who have purpura ulcers only in the cold weather, sometimes renal involvement. So as the name suggests, the serum of the patient is clear at 37 degrees centigrade, but at the 4 degrees centigrade, this serum precipitates. So this is the cryoglobulins, the abnormal proteins in the blood which get precipitated in cold weather, and these then clot the blood vessels, evoke inflammation in the blood vessels, causing cryoglobulinemia. So abnormal proteins or cryoglobulins can be a result of either a monoclonal disease like a B-cell lymphoproliferative disorder, or a consequence of chronic infection like hepatitis C, or autoimmune diseases like Sjogren syndrome, and a condition called essential mixed cryoglobulinemia, where it can, in varying levels, these cryoglobulins can be there. So they can present with either purpura, which may be a very dense purpura. They may be purpura evolving to hemorrhagic blotchy spots, sometimes leading to deep ulcers on the shins. With, of course, they can have renal involvement because they involve capillaries. They can have pulmonary involvement rarely, and they can have neuropathy. Cryoglobulinemia are treated according to cause. If you have a patient who is hepatitis C positive, this is one condition where interferon as well as ribavirin both are used. Apart from glucocorticoids. If patient is not infected with any specific infectious agent and a primary cause is not there, you treat with rituximab and high dose glucocorticoids. If renal involvement is there, then you need to use cyclophosphamide or sometimes plasma exchange. So this is the crux of our presentation now. What is the approach to vasculitis? So suspecting, need to have a very high index of suspicion, because sometimes, only sometimes the evidence adds up. Most of the time it doesn't add up. And a cross-sectional snapshot of the patient you will be unlikely to make a diagnosis. You need to look at the history, past events, evidence from the investigations, evidence from response to treatment in the past, and sometimes so many other things. So first and foremost, you need to ask yourself, is it a vasculitis mimic? There are conditions, is it a vasculopathy or a vasculitis? Is there an underlying cause? कोई connective tissue disease है, RA का background है, SLE का background है, drug use है, या फिर कोई infection है. Extent, what is the extent? Organs कौन कौन से involved हैं? ये बिल्कुल malignancy की तरह आपको plan करना पड़ता है. Kidney involvement है, skin involvement है, neurological involvement है. Then आपने सोच लिया तो, लेकिन before giving a huge immunosuppression, you need to be very sure. How do you confirm that diagnosis? And what is the specific type of vasculitis? So mimics of vasculitis, first and foremost, think of antiphospholipid antibody syndrome, atherosclerotic disease, and any drug use like cocaine, hypersensitivity reactions. For medicine, infected endocarditis, every suspected patient of small vessel vasculitis never failed to do an echo. Multiple myeloma, paraneoplastic syndromes, and secondary causes like connective tissue diseases and malignancies and infections, and sickle cell disease also. These are mimics of vasculitis. So when you have vasculitis mimics, you need to do blood cultures, you need to do echo, you need to do serology for viruses, you need to do antibodies. Only then you can make a reasonably good diagnosis. Look for specific clues in clinical presentation. This is a slide I've made from my own clinical experience. Systemic features are common to most vasculitis. They actually give you the suspicion that you now need to look for such a disease. So fever, joint pains, myalgias, weight loss are very commonly seen. More the history, longer the history, more is the chances of having these manifestations. If you have predominantly ENT and head and neck involvement, think of GPA. This is one disease which preferentially involves this area. If you have predominantly pulmonary involvement, think of ANCA-associated vasculitis as a whole as a possible etiology, because this group can involve lung. If you have neuropathy, neuropathy means multiple mononeuritis multiplex, that is medium vessel involvement. So think of PAN, think of GPA, think of eGPA. Microscopic polyngiitis, I have seen that not very commonly, but ANCA-associated vasculitis and PAN are two possibilities. Cryoglobulinemia will give itself away with history of a seasonal variation. So that is also a cause of neuropathy, but not as commonly seen. You are having a patient who has absent pulses, there is carotid artery tenderness, there is renal artery stenosis, there is coronary artery involvement. Think of, in a young female, think of Takayasu. You have a glomerular renal involvement. So glomerular means that the creatinine is high, it is rising rapidly, or has risen significantly over the past few weeks with active urinary sediment. Think of ANCA-associated vasculitis. You have renal involvement which is non-glomerular, creatinine around 2, hypertension, bland urinary sediment, prominent features, some neuropathy. Think of PAN. So this is how you go about it. You identify, you just treat it like a malignancy, make a diagnosis, map the extent of disease, confirm the diagnosis with whatever means you have, and then go about treating it. This slide is worth repeating because this gives you that clue. Large vessel involvement has its own specific features. Medium vessel involvement has its different features. Small vessel involvement can have different features. They can overlap. Large vessel vasculitis, Takayasu can have purpura, but less commonly. Medium vessel involvement, PAN does not usually have small vessel involvement, but many ANCA-associated vasculitis are overlap of these two conditions. So that is how you make that diagnosis. You have history of oral ulcers, you have history of genital ulcers, serology not matching, think of Behçet's disease. You have isolated 8th nerve involvement, think of Cogan syndrome. So these are things which gives you a clue about how to just think out of the box and make a diagnosis in such a challenging case. Skin is often the clue. Look very closely. This is, anybody? I haven't put a name here. Livedo reticularis, mesh-like appearance of blood vessels. ये तो बहुत commonly मिलता है. Infected endocarditis तो सबने देखा होगा. Splinter hemorrhages, subcutaneous nodules, dermal infarcts, digital gangrene. So Dr. Rajiv Agarwal sir is here. He once referred a patient to me in his ICU that we have a patient who has digital gangrene in a non-confirmatory vascular pattern. These were the exact words. So I think you are needed here, and that is very apt. So अगर किसी को radial artery का involvement है या किसी known branch का involvement है, you can actually predict. एक तो आपको Doppler में finding मिल जाएगी उसमें, and secondly आपको एक characteristic pattern में आपको ischemic involvement मिलेगा. लेकिन अगर आपको scattered pattern में मिल रहा है और point of time में अलग-अलग time पे है, इस limb का involvement हुआ, फिर इसका हुआ, think of vasculitis. ये vasculitis की talk है, इसका ये मतलब नहीं है कि हम connective tissue diseases को भूल जाएं. ये सीजन रेनॉल्ड्स का है. इस टाइम रेनॉल्ड्स फेनोमेनन की वजह से डिजिटल गैंग्रीन के बहुत पेशेंट्स आपके पास आ रहे होंगे. बट दैट्स अ सेपरेट सब ग्रुप ऑफ पेशेंट्स. उनको यू कैन इजीली मेक देम आउट. Just pinch on the dorsum of their fingers, you will find that the skin is so tight. And look closely at their face. They might have become darker over the past few months. Their nose might have become pinched. Their lips might have thinned out. That is systemic sclerosis. That is a vasculopathy, not exactly a vasculitis. Okay, so Raynaud's is there, but Raynaud's can exactly look like this, but these subtle differences you can make out. If that is not the case, think of vasculitis. So exclude vasculitis mimics with the help of blood cultures, echo, hepatitis B, C, HIV test, do an anti-GBM antibody, anti-phospholipid antibodies, anti-nuclear antibody, depending on the clinical presentation. Patient के symptoms हैं, तो आप कराइए इनको, नहीं तो मत कराइए. Then assess the extent of vasculitis, look for kidney involvement, look for chest involvement, look for NCV if needed, and then if you have a reliable index कि यहाँ से मुझे biopsy में diagnosis granulomatous inflammation या evidence of vasculitis मिल सकता है, सबसे commonly आपको skin से मिलता है, then you can go ahead and do it. Then also do specific antibodies, ANCA we just discussed, cryoglobulin we just discussed. If patient is complement levels, usually they are high in patients of vasculitis, so I usually don't do them. Eosinophil counts if patient is suspected of EGPA, and sometimes you need to do specific tests based on specific etiologies also. So that is how you use this algorithm. Think of it is again a gist of what we just talked. Small vessel, work up accordingly. Look for skin involvement, kidney involvement, pulmonary involvement, and medium vessel, work up accordingly. Medium vessel के अलग organs involved होंगे, large vessel के अलग organs involved होंगे. So that is how you go about it. Thank you very much.
Thank you, sir, for the detailed description of the hidden treasures of medicine. The floor is open for discussion, and I'll hand over mic to chairperson.
So any questions from the audience? I think, yeah, please go ahead. Go ahead.
You have given such a good idea regarding the vasculitis and very good, very nice. But this is a very, very common complaint of the patient. हमारे शरीर में सूजन होना है, and we can get तुम्हारी feelings है, because we are watching it, and anywhere the fluid is accumulated. But to think that you are giving such a good idea, because all the requires and inflammation is the real disease of living so find it out how we can check it. I'm not asking the question where I have arrived in my research that intermittent fasting is good fight to avoid all these people, albuminuria, what for that, albumin and glucose exhaustion, and it makes many patients careless and non-implemented. So, how much do I accept?
Okay, there are two parts of this question. One is inflammation, one is vasculitis. If you're dealing with a specific cause of vasculitis, there is cause of inflammation like vasculitis, then you need to treat the primary cause first. Only then it is going to be involved. There is a second thing which you are discussing is about inflammation without a specific cause. बहुत सारे cardiac patients में high sensitive CRP कराया जाता है, बढ़ा हुआ मिलता है. It is believed that the origin of that CRP is also from the vascular endothelium. And endothelial dysfunction is the root cause of atherosclerosis. And atherosclerosis leads to micro and macrovascular morbidities, which is seen in lifestyle disorders. So I cannot agree more with that. You are absolutely right. If you are dealing with such kind of inflammation, which is endothelial dysfunction, then lifestyle management, dietary management, and specific pharmacological involvement like evidence interventions like statins are the cornerstone of therapy. No, that is not really autoimmune in etiology, but immune pathways, there is an overlap. Autoimmune etiology leads to inflammation, inflammation leads to the pathology of the disease. So the incitement of the inflammation comes from autoimmunity. So you target that autoimmunity by immunosuppressive medications, it works. The inflammation can be non-autoimmune in origin. It is a vascular inflammation triggered by accumulation of LDL inside the vessel wall. It is believed anti-LDL antibodies also are at work there, which has been done. I also worked on that area during my research years. So that actually responds to lifestyle disorders. So you need actually both. You need to, that is the job of a clinician to identify you're dealing with a specific cause here or a non-specific cause here. And that is how you tailor the treatment.
I hate to do that, but in the interest of the
yes, thank you, sir.
We have to stop you. I'm so sorry, we have to stop you there. We have a question after Sandeep would be very glad to answer it.
Yes, thank you, sir.
Thank you very much, Dr. Sandeep. You've done a good job.
What a splendid talk by Dr. Sandeep Grover, sir. Thank you, sir, for your insights. Hope we will have a easier time managing patients with vasculitis now. I would like to request Dr. Saurabh Singhal, sir, to present the chairperson and speaker with a token of thanks.
First of all, Dr. Sandeep Grover, sir, the speaker. Aaron, sir.
Up next, I wanted to request Dr. Sumit Kant Jha, sir, to invite our next set of chairpersons and speaker, Dr. Rajiv Agarwal, sir, who would be presenting a talk on community approach to cardiovascular risk reduction. PPT.
Well, we are a bit short of time and there's just change of schedule. We are taking the cardiology seminar first. For that, I would like to invite our chairpersons, Dr. Rahul Bansal, sir, our first chairperson for the talk for cardiology. Sir has done MBBS and from LLR Medical College and MD in 1988. He has worked in different medical colleges before coming to Subharti, and he has almost worked for here since 2004. Sir is a very renowned person for his approach to medicine. He is attached with the yoga and the basic medicine and the naturopathy as well. Sir is running his clinic as Soul and Mind in Meerut. He has published more than 60 research articles in national and international reputed journals with more than 138 citations and Google estimates of 6. Sir Rahul Bansal sir, you are invited on stage. Next chairperson is Amit Sharma sir, Dr. Amit Sharma. He has done MBBS from Medical College Jhansi in 2002 and MD in Medicine from Lucknow, KGMC Lucknow in 2007, and then he went for PM Cardiology from RML Hospital, New Delhi, 2013. Presently, he is Director of Cath Lab, Kailashi Super Specialty Hospital, and also attached with us for his work. Our third speaker, chairperson is Abha Gupta ma'am, Dr. Abha Gupta ma'am. She is presently Professor and Head of Department of Medicine from LLRA Medical College. She has got Fellowship of Indian College of Physicians, IACM and RSDDI. She had published 6 chapters, 3 papers in the international and more than 20 publications in the national journal. She was awarded Bharat Jyoti Award in 2015 from IACM and Professor BCM Bansal Award for Best Paper Award in 2016. And she has also been the Investigator of the Year in 2017 and 18 by the Indian Society of Hypertension. I would request Abha Gupta ma'am to proceed the session and introduce Rajiv Agrawal sir for the session.
Thank you, Dr. Jha. First of all, I pay my tribute to Mukti Bhatnagar ma'am, a person very close to my heart, a multifaceted personality, be it academics, painting, singing, poetry. And I still remember one day she texted me that, Abba, I have learned palmistry. I requested her to read my hands. I sent the photograph of my hands, and after some time she wrote, Abha, you have to be strong. Something harsh is going to happen in near future. And after 2 weeks, I was transferred from LLRM. She again called me up. Actually, she wanted me to join over here. She had asked earlier also. But as you know, after spending more than 15 years in government job, it's not very easy to leave that job. So unfortunately, I could not get the chance to work with her. Now coming to the task given to me, introduction of Dr. Rajiv Agrawal, a real Herculean task. If I start enumerating his credentials, this will take more time than his actual talk. और मुझे लगता है कि जिन्हें बच्चा बच्चा जानता है उन्हें मैं क्या इंट्रोड्यूस करूं. He is chairman, Sushila Rai Jaswant Multi Specialty Hospital, a person dedicated to free pacemaker implantation, and in fact on 13th February of this year also he is going to organize a free camp for pacemaker implantation. Dr. Rajiv Agrawal, वैसे डेट आपने बड़ा सोच समझ के चूज की है. पहले दिन पेसमेकर, दूसरे दिन वैलेंटाइंस डे. वेरी इजी टू रिमेम्बर, 13th Feb. So without taking much time, I invite Dr. Rajiv Agrawal to start his derivation. Thank you.
Good morning, everybody, and it is a very nostalgic moment for me to be here in the memory of Dr. Mukti Bhatnagar. Those, I think all of you don't know that just after marriage, she joined as school officer to Professor G.P. Allen's unit, and I was house officer of the unit. I remember her very, very vocal about her opinion in front of Professor G.P. Allen, who was such a towering personality. And she will on round disagree with her, give her opinion, And sometimes used to prevail, sometimes she had to surrender. And I used to tell, Madam, itna jhagda na kara. Because we were too much afraid of his personality, persona, knowledge, wisdom, those kind of things. And my relationship with her continued till her death. I could not meet before her death because she never confessed anything to me. She used to call me at random, talk all the nonsense things around and what is going on in Subharti, this and that. And whenever I needed any help in Subharti, I never approached Dr. Atul Bhatnagar. I always approached her and she will say, "Tum Atul ke paas jao, कहना मुक्ति ने भेजा है." And whenever I entered his office, Dr. Atul Bhatnagar always told me, जो भी उनके इर्द गिर्द होते थे, ये मैडम का लड़का है भाई, इसकी बात सुन लो, काम कर लो इसका. That was my relationship with both of them, and we enjoyed very good relation, both of them, and particularly I am very nostalgic with Dr. Mukti Bhatnagar today. I am a very late riser. I don't get up early in the morning because I sleep around 2:30 in the night. That is my biological clock. I don't accept any invitation meeting in public or private before 12:30 in the morning. But since it was such a special day for me to be here, that I accepted this to be here early morning, at least for me. I'm going to talk very, very simple, which will interest you, and some of you may feel why an intervention cardiologist is speaking prevention. And I'm sure by the end of talk, you will understand that it is very, very important to understand why we talk what we are talking. This is Dr. Alvin Roth, who was an economist and was awarded Nobel Prize in 2012. And he made a very significant contribution in relation to community, that diseases are more expensive than health. And I think that is the essence of my talk, that if you invest in earning health, you spend far less if you want to become healthy after disease in that perspective. So maintaining health is always cheaper, cost effective, and long lasting. As a cardiologist, we are obsessed about atherosclerosis. This is Sushruta Samhita, 600 BC. And the description of angina, the pain travels to the left arm and sometimes also to the tip of the fingers. Occasionally, the pain may also ascend to the shoulder, and the disorder is called Hridaya Shul. That was the description 600 BC. And there is no better description of atherosclerosis, ischemia, or angina till today. Only thing, we could not ascertain the cause of atherosclerosis in Sushruta Samhita. Then you look, William Haverden, who is being credited for describing angina, in 1768, I think the description is more or less same. And unfortunately, Sushruta Samhita's description is not acknowledged in literature. This is a normal looking artery. You have 3 layers: intima, media, adventitia. The intimal layers are the biggest endocrine gland of the body. They secrete so many hormones that this is the biggest endocrine gland of the body. And to make it simple, if you have atherosclerosis, you have deposition like this in subintimal space, and the narrowing is more than these vessels, depending upon the organ involved, will cause ischemia. They may cause ischemia in the leg. You will call them intermittent claudication. They may cause angina in the abdomen, which you may have a kind of postprandial angina. They may cause cerebral infarct. In fact, you all belong to Western UP. We often use in common language one word, ye satya gaya hai. And that means he is mentally subnormal, reflecting probably cerebral atherosclerosis at 60 years of age. So there is, depending upon the organ involved, we have symptoms related to that organ because of the obstruction. And if this plaque, this lipid-rich plaque ruptures, it causes acute ischemic syndrome, like you can have stroke, you can have MI, you can have something like leg attack, or you can have mesenteric ischemia. Depending upon this, you can have splenic infarct. So that is how we are positioned in terms of atherosclerosis. And if you combine these two top diseases, cerebrovascular and coronary artery diseases, they, as a group, they are the largest group among all the diseases. And why we have to group them? Because the treatment and the approach of prevention is same. Atherosclerosis, like tuberculosis, in any organ, the treatment remains the same. One confusion which happens to not students but to all of us is we feel atherosclerosis is the disease of the middle age. I define again, atherosclerosis is a pediatric disease. It happens in early years of life. It matures in middle age. And this is what we have shown, that if you do an endoscopic study of the arteries of young individual between 13 to 19 years, 20% of such people have atheroma in their arteries. So atherosclerosis is a pediatric disease. It begins early in life. And why I teach so, because the prevention strategies which we are going to unfold in next 25 minutes or so, they are most effective at that point of time. If you start walking at 50 years of life, you are already having high probability of the disease. The reversal of disease is very difficult. Prevention of disease is easy. Another thing which we have come across is fatty streak formation occurs in human fetal in aorta and is greatly enhanced by maternal hypercholesteremia. So if mothers are having too much of fatty diet, like we are treating our pregnant ladies with rich diet, they gain almost double the weight. Then you can imagine that fatty streaks can be seen even in early years of life at birth. Fetal aorta in pregnant women with familial hypercholesteremia shows atherosclerosis. Once again emphasizing that atherosclerosis is a pediatric disease. Social environment as a factor in diet-induced atherosclerosis. Again, those who are in loving care, tender care, they have less atherosclerosis than individuals who are put in hostile environment. So even emotional factors contribute to atherosclerosis. And this is not just conjecture. This data is all validated by histopathology. So once again, ending up this basic concept that atherosclerosis is a pediatric disease which matures in middle age. The another fundamental issue which you should carry home is atherosclerosis never sleeps. So if you have CVA, if you have MI, there is nothing like complete recovery from the event. This is a misnomer. If a CVA patient recovers 5 by 5, or a heart attack patient recovers without injury to the muscle with the ejection fraction of 55%, that does not mean the end of event. That means the event had been recovered, but the disease is going to progress relentlessly lifelong. And that is why in these patient prevention strategies should be practiced lifelong. So atherosclerosis is not event-based. It is a lifelong intervention despite full recovery from the event. It is not appendectomy. It is not cholecystectomy. It is not perforation of the bowel. These diseases are to be tamed lifelong. And I'll just end up this conceptual portion of my talk that atherosclerosis creeps while you sleep. So never understand that atherosclerosis is gone. I often tell my patients, आप जो समझ रहे हैं बीमारी खत्म हो गई है, खत्म नहीं हो गई है, सो गई है. So we can make this disease noiseless, but we can't eradicate the disease. And we have to emphasize this point with full vigor to our patients. This is Dan Kava's study, which was published very recently, which talked about a very important fundamental concept. Fundamental concept was, हम मरीजों के रिस्क फैक्टर कंट्रोल करें या मरीजों की जांचों से हाई रिस्क पेशेंट पकड़ें. एक पॉपुलेशन वो है जिसमें हम कहते हैं फ्रूट्स खाओ, नमक कम खाओ, पैदल चलो, और एक पॉपुलेशन वो है हम आप सब लोगों के कैरोटिड स्कैन करके ये देखें इंटीमा मीडिया थिकनेस किसकी बढ़ी हुई है और उन सब लोगों के इलाज शुरू कर दें. So people thought that this second approach is very evidence-based, it should work, but it didn't work. Because you are already late in the disease. You have manifested disease. You have gone into secondary prevention. So when we manage risk factors, we are in primary prevention, and that helps a lot. So that is one very fundamental aspect, fundamental understanding you should carry home is risk factor management is superior than imaging-based high-risk individual management. This is just a very notorious slide, but very good slide. If you live fast, you die young, and you sleep later. So what we have to do, we have to sleep in beginning so that we live longer. And I'll tell you what I mean by this. This is President Eisenhower. He had a heart attack. He was a smoker. And everybody was surprised why Eisenhower got a heart attack. So in that time, Paul Dudley White was one of the biggest American cardiologists. He was called upon to look after the president. And it was found that president is smoking. And Paul Dudley White at that point of time told complete bed rest is wrong. Paul Dudley White saved his life. Paul Dudley White rode a bike. Smoking causes heart attack. Lifestyle changes to avoid heart attack is reasonable. Low-fat diet recommended. But Ike was the nickname of President Eisenhower. Ike did not change enough, and he died in March 28, 1969. He had 14 times cardiac arrest, revived. So proving that Paul Dudley White was right because he did not quit smoking. And that led to the formation of Framingham study. Framingham study was created after that we should know our president has died of heart attack. We should know what are the factors which cause heart attack, and HDL as a protective molecule came out of Framingham heart study. Whole cholesterol hypothesis, hypertension, diabetes, everything you know today is the outcome of Framingham heart study. If you look at the modifiable risk factors following first myocardial infarction, you find despite knowing everything on earth, the risk factor profile is marginally increasing, it is not decreasing. So our education is not moving out of teaching rooms to the community. And that's why I chose the topic that whatever you learn today in medicine should reach out the community, because risk factors are not changing. They are, if at all, marginally increasing. We have culture of having foods which makes us strong. Like our ladies are overfed during pregnancy and after pregnancy. Weight is not the consideration. I always say your weight is your energy passport. If you are overweight, you're not supposed to eat it. If you are underweight, yes. हम यहाँ जाड़ों में साग खाते हैं, कितना हाई कैलोरिक खाते हैं. Saag is good, but we add oil to it. So our culture needs to be modified according to our lifestyle. The paradox is the golden calories are expensive. The black calories are cheap. Like you can have 2 omelets, 2 samosas, 2 bread pakoras, maybe in less than 100 rupees, and you are done. But if you want a boiled rice, chapati, and the dal, and a green vegetable, it will cost you a hell lot of money. So that is the paradox of the society, that bad calories are cheap. मैं एक लेक्चर में हूँ, 10 मिनट में बात करूँगा. Okay? So that is the problem, that black calories are cheap. आप समझ देखते हैं सड़कों पे रात भर रिक्शा पुलर्स वाले आमलेट खाते हैं, ब्रेड पकौड़े खाते हैं, कचहरियों में विलेजर्स आते हैं, वो पकौड़े खा रहे हैं, बिकॉज दे आर चीप. दे कांट हैव अ वेजिटेबल थाली कॉस्टिंग 500 रुपीज. सो हाँ बेटे, मैं एक लेक्चर में हूँ, 15 मिनट में कॉल करूँगा. ओके, ठीक है. So that is one, we have to make change in our eating pattern. And the another thing which you must carry home, that black calories are cheap calories. So obesity is translating from affluent class to poor class. जो सबसे बड़ा इनोवेशन अब हो रहा है, अब आपने आजकल अपने आंखें खोल के देखा करिए क्या हो रहा है. अब ये इलेक्ट्रॉनिक ड्रिवन रिक्शा चल गए हैं. पहले रिक्शा मैनुअल थे, अब ये इलेक्ट्रॉनिक रिक्शा बन गए हैं. और इनके ड्राइवर्स का आप ग्रेजुअली देखिए, मैं ऑब्जर्व कर रहा हूं पिछले 2-3 सालों में इनका वेट बढ़ रहा है. और ये सब फ्यूचर कॉरोनरी डायबिटिक इस्कीमिक स्ट्रोक के पेशेंट बनेंगे, बिकॉज मैनुअल लेबर हैज बीन चेंज टू a technical or a science driven labor. They are making money, but the pattern of life has changed, and these people will not reduce their black calories. They will continue to eat the same. So I expect this electronic rickshaw driven population is a future target for all these non-communicable diseases, because suddenly you have changed the pattern of their life. जो भी हमारे ट्रीटमेंट हैं, जो रिस्क फैक्टर मैनेजमेंट है, वो लाइट ग्रीन है. इसमें देख रहे हैं आप, रिस्क फैक्टर मैनेजमेंट जो है वो लाइट ग्रीन है, और ट्रीटमेंट पार्ट जो है वो डार्क ग्रीन है. तो किसी भी बीमारी में रिस्क फैक्टर मैनेजमेंट का रोल इक्वल है, इंफीरियर नहीं है. बट हमारे पेशेंट और डॉक्टर दोनों लोग प्रेस्क्रिप्शन पे ज़्यादा बेस करते हैं. हम अपने मरीजों को स्मोकिंग क्विट करने के लिए फोर्स नहीं करते हैं, हम अपने मरीजों को डाइट के लिए नहीं फोर्स करते हैं, वेट के लिए नहीं फोर्स करते हैं. आपको मैं एक बड़ी सिंपल ट्रिक बताता हूँ. मैं अपने मरीजों के सिंपल वेट लिखवाता रहता हूँ और उनको गिल्टी फील कराता रहता हूँ. उनको मैं होमवर्क दे देता हूँ कि 2 महीने में अच्छा भाई 3 किलो वजन कम कराना. तो 82 से गए, अगली बार आए, परहेज हो रहा है, 83 हो गया सर, 84 हो गया. So you make them conscious of their weight. There are simple things you have to make conscious of them. If you only work on risk factor profile, probably it will be only very small number of people who will be benefited, because large number of population is
on the sides with less metric derangements. So when we are coming to this topic, we are primarily aiming for community-based primordial prevention, which is the most cost-effective way to deal with the community, and weight reduction, DASH eating plan, dietary sodium restriction, physical activity, moderate alcohol consumption, all this can reduce blood pressure significantly. If you reduce your weight by 10 kgs, you can reduce your blood pressure by 5 to 20 millimeter of mercury. They are very effective strategies, and we need to enforce on the community. Then about tobacco use, it is very, very important that you push your individual patients on tobacco abstinence. More time you invest, more is the outcome. There is no safe limit of cigarette smoking. Many people say हम खाने के बाद एक खाते हैं. Many people say हम सुबह को मोशन के लिए खाते हैं. तो आपको एनफोर्स करना है कि टोबैको का यूज किसी भी लेवल पे नहीं करना है. टोबैको से अल्टीमेटली एथेरोस्क्लेरोसिस हो जाती है और वो सब उसी किस्म के इस्कीमिक इवेंट करती है. एंड बेसिकली वी हैव टू डू a wider education, advertising, smoke-free law, smoking taxes. That kind of approach has to be done, which is the biggest reward for the community. एक चीज मैं आपको बताता हूं बहुत अच्छी, इसको आप ध्यान से सुनिए. सब लोग हमारे यहाँ सीनियर लोग बैठे हैं. एक स्टडी हुई है यूकेपीडीएस. सारी डायबिटीज की फाउंडेशन यूकेपीडीएस पे बेस्ड है. और यूकेपीडीएस में बताया कि अगर आप 1 मिलीमोल कोलेस्ट्रॉल कम करते हैं, यानी 1 मिलीमोल का मतलब होता है एलडीएल का 40 मिलीग्राम, तो आप 57% रिस्क रिडक्शन करते हैं. सबसे पावरफुल इंटरवेंशन है. पर लोगों ने एक बात कभी नहीं बताई. वो बताई कि अगर आप स्मोकिंग छोड़ दें, क्विटिंग स्मोकिंग इज ऑल्सो 60% रिस्क रिडक्शन. यानी स्मोकिंग छोड़ना और कोलेस्ट्रॉल लोअर करना इक्वली पावरफुल है. अगर डायबिटिक बंदा स्मोकिंग छोड़ दे और एलडीएल 1 मिलीमोल कम कर ले, वो अमर हो गया, कुछ नहीं होने का. लेकिन हम एलडीएल के पीछे लगे रहते हैं, स्मोकिंग के लिए इतना मरीजों को पावरफुल नहीं बनाते. दिस इज स्मोकिंग एंड नॉन स्मोकिंग. रेड इज स्मोकिंग एंड लोअर वन इज नॉन स्मोकिंग. See the gap between the two. If you are a smoker, your gap is exponentially increased and you have higher events. So same level of cholesterol, if you are a smoker, it magnifies the effect. और ये सबसे सुंदर स्लाइड है. मुझे नहीं पता कितनी आपको दिख रही है, लेकिन ये सबसे सुंदर स्लाइड है. इसमें सबसे पहले एक्सट्रीम लेफ्ट पे लिखा है एस्पिरिन, एस इनहिबिटर, बीटा ब्लॉकर, स्टैटिन, और सबसे ज्यादा इंपॉर्टेंट रोल है क्विटिंग स्मोकिंग. हम सब लोग बीटा ब्लॉकर के पीछे लगे रहेंगे, एस्पिरिन के पीछे लगे रहेंगे, सारी दवाइयां बताएंगे उसे, और जो सबसे पावरफुल काम है क्विटिंग स्मोकिंग, वो नहीं करते. तो आस्किंग द पर्सन क्विटिंग टू क्विट स्मोक इज वेरी वेरी इंपॉर्टेंट इंटरवेंशन. ये हार्ट फेलियर में भी काम करती है. अगर आप स्मोकिंग छोड़ दें तो हार्ट फेलियर भी कम होता है. और ये सब उसके मैकेनिस्टिक पाथवे हैं कि हार्ट फेलियर में भी स्मोकिंग छोड़ने का एडवांटेज मिलता है. डाइट एंड न्यूट्रिशन, हमें बहुत सारी वेजिटेबल, फ्रूट्स, लेग्यूम्स ये खाने चाहिए, और सैचुरेटेड फैट को डाइटरी मोनोसैचुरेटेड और पॉली अनसैचुरेटेड फैट से बदलना चाहिए. वेजिटेबल ऑयल्स लार्जली पॉली अनसैचुरेटेड फैट होते हैं. एनिमल सोर्स के जो फैट होते हैं वो ज़्यादातर सैचुरेटेड होते हैं. प्लांट बेस्ड हमें फैट खाने चाहिए.
हम अक्सर ये महसूस करते हैं कि हम खाना खाते हैं, लेकिन ये बड़ी पावरफुल कोट है, ह्यूमंस ईट फूड, फूड डज नॉट कंज्यूम ह्यूमंस और सो वी थॉट। अरे खाना भी आदमी को खा लेता है, जो मोटा हो जाता है उसका खाना ही आदमी को खा लेगा। तो आप समझिए, इस कंफ्यूजन में मत रहिए, हम खाना खाते हैं, खाना भी हमें खा जाएगा अगर ज्यादा खा जाएंगे। और वंस अगेन वी हैव टू गो टू प्राइमोर्डियल इंटरवेंशन ऑफ टीचिंग अवर चिल्ड्रन। जैसे एक हमने 100-125 बच्चों का, एक बहुत पहले मेरे साथ डाइटिशियन रहती थी, सर्वे किया तो डॉक्टर्स की फैमिली में 30% ओबेसिटी है बच्चों की। नॉन वर्किंग वाइफ्स वो खाना नहीं बना रही, वो पता नहीं किस काम में बिजी है। और बच्चों को स्कूल में एक मनी दी जाती है कि जाके कैंटीन में खा लेना। कैंटीन में क्या मिलेगा? पिज्जा, बर्गर, कोल्ड ड्रिंक। सो अ चाइल्ड हु इज ब्रॉट अप विद दिस फूड, व्हेन ही बिकम्स हाइपरटेंसिव एट 35 एंड नाउ यू से हिम कि अब तुम घी की सब्जी खाओ, हाउ कैन ही ईट? So the biggest problem we are facing today, permit me to say so, with the liberalization, women liberalization, the kitchen has died out. Our ladies have stopped taking into account what is being cooked in the kitchen. Don't cook, at least supervise. आज बच्चे टिफिन लेके ही नहीं घर जा रहे हैं। आप अपने अपने घरों में पूछेगा, आप सब लोगों की तो उम्र कम है, आपके बच्चे क्या घर से टिफिन लेके जा रहे हैं? कोई नहीं लेके जा रहा। सबको पॉकेट मनी मिल रही है कि वहां पिज्जा, बर्गर, कोल्ड ड्रिंक वो पीजिए, और फिर जब 35 साल में डायबिटीज हो जाए तब आप फाइबर डाइट, फ्रूट्स, इन चीजों की बात करें। आई वॉज विद अ वेरी सीनियर IPS ऑफिसर, उनके बच्चे ऐसी बातचीत चल रही थी, तो मैंने कहा इसको तो घी की सब्जी भी नहीं पता होगी, घी तोरी का रायता नहीं पता होगा इसको, घी की इसने लौज या बर्फी नहीं खाई हो। Nobody makes it because everything is fast food based. The problem is we have stopped working in the kitchen. We have stopped supervising kitchen, with the result that our children are not being developed with the taste of food which we should have been favoring. Again, the same thing. If your diet is low in fruits, green vegetables and dairy products, then you are on top. Your blood pressure is high. If your diet is enriched in fruit, vegetable and fibers, then you are at the middle. And if it is low fat and cholesterol, then it is right at the bottom. So your diet affects the vascular health. This is salt intake. We should have at least 3 grams of salt. China and USA, they take about 4 to 5 grams of salt. Indians, they take about 9 grams of salt. So our salt intake is almost 2.5 times to 3 times of the recommendation, with the result, as you know, at 4 or 5 grams, the survival patterns keeps on decreasing. So salt intake is very, very important, that you should not add salt on the chaat masala. You should not add salt on the salads. You should try to eat less salt. ये एक सिंपल मैं अक्सर दिखाता रहता हूँ, that is how a food is being served. आपने एक अपना कॉफी और ये सब लिया है, तो इससे पैटर्न पता चल गया कि इस खाने से कितनी कैलोरीज खा ली आपने, कितना फैट खा लिया, कितना कार्ब और कितना सोडियम, और आपके पूरे दिन का कितना खा लिया. We have to make you conscious what you are eating. Salt intake is very, very important, and as the salt intake decreases in the community, then the risk of stroke and everything keeps on decreasing. They have a mandate in Portugal, 30% reduction of salt in any packaged food. There is a blanket government order which has reduced 5 millimeter mercury of blood pressure of the community. which has resulted in around 25% reduction in ischemic strokes. So salt reduction is very, very important, and we need to have these kind of legislation where salt can be reduced. Salt substitution is not an answer, because what happens if you make salt substitute, then it is like आप अपने salt में मैं एक inert sand मिला दूं तो आपको टेस्ट नहीं आएगा, तो आप ज्यादा डाल देंगे. तो सॉल्ट सब्स्टिट्यूट से फायदा नहीं होता. सॉल्ट एंड शुगर एंड फैट, दे आर लर्नड बिहेवियर, दे आर नॉट इनेट बिहेवियर, दे आर नॉट जेनेटिक बिहेवियर. जैसे जापानी आप देखते हैं बिना सॉल्ट का खाते हैं. तो सॉल्ट, शुगर एंड फैट इज एन एक्वायर्ड लर्नड बिहेवियर. If you teach your children to take less salt over a period of time from the beginning, they will addict to it. So that is what is there, that high salt intake is bad for the community. And हमारे यहाँ चटनी, अचार, चाट मसाला, ये इस किस्म के जो कहते हैं Indian curries, we are rich in salt food. Probably because of tropics, we sweat a lot in summer and we need more salt. But round the year intake of salt is hazardous. Mediterranean diet, you know, this diet is based on fish, red wine, cheese, and they have shown that there is lower event rate, lower incidence of prevalence of coronary artery disease. This is a blueprint what you should have in your stomach. Minimum oil, on the extreme right, lot of vegetables and fruits. ये बड़ी एक अच्छी quotation है, इसको आप याद करिए. And this is a true quotation. Whatever you eat, 1/3 you eat to feed your body, 2/3 you eat to feed the doctor's family. क्योंकि उसके बाद आप बीमार पड़ेंगे, अपना ब्लड प्रेशर का इलाज कराएंगे, किडनी का इलाज कराएंगे, संदीप गर्ग से, अरुण शर्मा से स्ट्रोक कराएंगे, हम छल्ले डालेंगे. तो 2/3 अगर आप ज्यादा खाएंगे तो आप परेशानी में रहेंगे. तो बेस्ट चीज ये है, eat less, and it is saying that you should be able to eat that much that you can eat again if there is an opportunity. जैसे हमारे यहाँ कहते हैं ना, पेट भर गया, इस लेवल तक नहीं खाना है, इस लेवल तक नहीं खाना. Exercise and physical activity. Avoid using lift at least 2, 3, 4 staircase. Walk. Use washroom which is far off. Try to pick up your own glass of water. घंटी मत बजाइए, पानी ले आइए, चाय ले आइए, ऐसे मत करिए. खूब वॉक करिए. मैं तो कहूँगा टीचिंग ब्लॉक में लिफ्ट होनी नहीं चाहिए. आपकी लव स्टोरी में, आई एम मैरिड टू अ गर्ल हु वाज जूनियर टू मी, एंड बिकॉज LLRM मेडिकल कॉलेज में लिफ्ट नहीं चलती तो हम जीने में ही बात करते थे. तो नॉट हैविंग अ लिफ्ट हैज गॉट सेवरल एडवांटेजेस. बियॉन्ड हेल्थ, यू विल फाइंड योर पार्टनर आल्सो ऑन द स्टेयर्स. एक्सरसाइज से वेजोडाइलेटेशन, माइटोकॉन्ड्रियल बायोजेनेसिस, एंटी इंफ्लेमेटरी इफेक्ट्स होते हैं. और ये इधर आप देखिए, जैसे ही आपका सीडेंटरी बिहेवियर होता है वैसे ही मोर्टेलिटी बढ़ जाती है. अगेन, जैसे ही डिक्रीज एक्टिविटी होगी वैसे ही मोर्टेलिटी बढ़ जाएगी. यू शुड हैव, सबके पास आजकल पेडोमीटर हैं, अपने मोबाइल्स में रखिए. एम मिनिमम ऑफ 10,000 स्टेप्स. Aim minimum. You have no reason not to walk 10,000 steps. I know police officers who walk 20,000 steps a day. मैंने उनको रात में चलते हुए देखा है, तो डॉक्टर साहब आज नहीं. There is no reason. Make a group of your friends, उसमें अवार्ड करिए, अपना एनुअल मंथली अपना चार्ट पोस्ट करिए और उसमें देखिए अपने कितने स्टेप्स चल रहे हैं. यू शुड वॉक 10,000 स्टेप्स एवरी डे. 7,500-10,000 स्टेप्स तक आपकी CV वो कम होती है. इसके ऊपर
बहुत ज़्यादा बेनिफिट नहीं होते हैं। तो 7,500 to 10,000 स्टेप्स आपको चलने हैं। ये देखिए, जितना मैक्स आप ज़्यादा खर्च करेंगे उतना ही मोर्टेलिटी कम होती जाएगी। जो 60 साल के नीचे ऊपर हैं वो अगर 5,000 स्टेप्स भी चल दे तो ठीक है, बट एम फॉर 10,000 स्टेप्स अ डे। हर चीज में देखेंगे आप, सीवी मोर्टेलिटी कम नहीं होती है। इवन जो लोग एक्सरसाइज करते हैं उनकी कैंसर की मोर्टेलिटी भी कम होती है, नॉन कार्डियोवैस्कुलर मोर्टेलिटी भी कम होती है। और आप मसल्स को मैकेनिकल समझते हैं। मसल इज अनदर एंडोक्राइन ग्लैंड। They produce several positive hormones which results in several biochemical changes which are good for body. They improve vascular endothelial function, vascular remodeling, angiogenesis, cardiac preconditioning, autonomic tone balance. And there are several such hormones called myokines. And they convert white fat to brown fat. And these irisin, FGF21 and maternal, these are some of them which are very, very protective hormones released by the muscle. Diabetes go hand in hand. If your weight is increasing, your probability of diabetes will also increase. And as the weight increases, your fat becomes infested with macrophages, and then it becomes inflammatory, and then they start producing bad hormones. So there is this stage called adiposity, when you are obese but not pathological. Then there is a stage called adiposopathy. जैसे अभी संदीप ग्रोवर ने बताया, देयर इज अ ओवरवेट पेशेंट, उसका सीआरपी बढ़ा हुआ, हम कहेंगे इसको एडिनोपैथी हो गई, सीआरपी बढ़ गया, इसका इन्फ्लेमेशन शुरू हो गया, IL-6 बढ़ गया, इन्फ्लेमेशन बढ़ गया. सो देयर इज अ एडिपोसिटी, एंड इफ यू कीप ऑन इंक्रीजिंग इट टर्न्स इनटू एडिपोसोपैथी, एंड दैट इज व्हाट इज, एज आई टोल्ड यू, द वेट इज एन एनर्जी पासबुक. Sleep is my obsession. Sleep well. If you're not able to sleep well, you will die young and then sleep later. So it is better to sleep while you are alive. 6 to 8 hours of sleep is very important, and it causes disruption of sleep, causes pro-inflammatory cytokines, sympathetic or oxidative stress, hypercholesteremia, decreased leptin, and increased ghrelin. जो लोग ज्यादा इंसोम्निया से ग्रस्त रहते हैं, उनको ग्रेलिन, भूख वाला हार्मोन बढ़ जाता है, वो खाते रहते हैं रात रात में उठ के, सोते नहीं, वो रात रात में खाते भी रहते हैं क्योंकि ग्रेलिन बढ़ जाता है. So this is insomnia and related to heart failure. And what are the defects? Difficulty initiating sleep, difficulty in maintaining sleep, early morning awakening, non-restorative sleep. So there are several sleep disorders which are associated with heart failure also. And then we have to define, create designs of our cities where walking is must. जैसे मैं आपको कुछ शहरों के नाम बताऊं, एक शहर है ज़र्मेट, स्विट्जरलैंड. वहां ऑटोमोबाइल अलाउड ही नहीं है, आपके पास कुछ हो ही नहीं सकता, पैदल चलेंगे या बग्गी बग्गी से चलेंगे. तो आप ऐसे सिटी के डिजाइन बनाइए, जैसे ऐसा करिए कुछ डिजाइन कि आप कैंपस में आपको कार चलाने का मौका ही ना मिले, आप पैदल चलेंगे बस. तो इन किस्म के कम्युनिटी फोर्स डिजाइन से आप कंपल्सिव वॉकिंग में पार्टिसिपेट करते हैं, एंड देन इट रिफ्लेक्ट्स ऑन योर हेल्थ. एंड स्ट्रेस इज अनदर थिंग विच इज वेरी वेरी इंपॉर्टेंट. ट्राई टू लर्न विदाउट स्ट्रेस. हर आदमी को स्ट्रेस रहना है, कभी एग्जाम का रहना है, कभी शादी का रहना है, कभी प्रैक्टिस का रहना है, कभी मरीज सीरियस हो गया उसके मरने का स्ट्रेस रहना है, कभी बाबूजी की बीमारी हो गई. तो ऐसा मत इमेजिन करिए कि आप स्ट्रेस फ्री रहेंगे, लेकिन स्ट्रेस में डी स्ट्रेस होकर रहना सीखिए. एंड स्ट्रेस से कोरोनरी आर्टरी डिसीज, स्ट्रोक, ischemic events, they are very, very common. Recurrence of event is stress related. Environmental pollution is also very, very important, and one of the reasons of increased diabetes and heart diseases, kidney failure is environmental pollution. There are various mechanistic pathways which I don't find time to communicate to you, but I can say it can cause epigenomic changes, that it can activate wrong kind of genes, tissue inflammation, thrombosis, plaque instability, endothelial damage, and vascular dysfunction. Yoga is very good for health, and yoga means just cooling off yourself so that you can be more comfortable and you can create a balance between parasympathetic and sympathetic system, and where your parasympathetic system is more activated. And I think one of the biggest health parameter which you can talk to a common man is resting heart rate. Lower the heart rate, better you are. If your heart rate is 90 at rest, you have poor vascular health. If your heart rate is 60 without drugs at rest, you are a very good candidate for vascular health. So resting heart rate without drug is one of the simplest way to communicate to the community about vascular health. Just I'll end up that community level actions have long lasting effect. They are behavioral changes which should be enforced by families, communities, and organizations. जैसे आप आज खाएंगे तो आपको बढ़िया सैलेड मिलना चाहिए, लेकिन हमारे यहाँ क्या मिलेगा? आलू और कचौड़ी और रायता और काशी फल की सब्जी. We do not encourage healthy meals in our day-to-day dealings. We should have sugar-free tea. We should have less of milk in our tea. So you have to restrict your energy intake at every point of time so that it becomes a community behavior. And that is what is health equity. If you do community level intervention, आपको भी उतना ही फायदा होगा, हमें भी इतना ही फायदा होगा, गरीब आदमी को भी, रईस आदमी को भी, सबको भी. तो जो कम्युनिटी बेस्ड इंटरवेंशन है उनसे हेल्थ इक्विटी बढ़ती है, इनइक्वालिटी नहीं बढ़ती. एंड देयर इज नो सच थिंग एज सडन हार्ट अटैक. It requires years of preparation. That means you work, don't look after yourself, and ultimately end up in ischemic events. And I'll tell you, one of the simplest way to understand is, unlike other mammals, our cholesterol is almost double. We are born, when a child is born, his cholesterol is around 120/30, and after 2 years of westernization, urbanization, and feeding, our cholesterol gallops to higher level. And that is the simplest explanation, that one of the reasons of having more ischemic events in today's population is our diet, inability to consume it, with the result our serum cholesterol keeps on rising. And this is what is nature has blessed us. Adult primates, हाथी को हार्ट अटैक नहीं होता, शेर को हार्ट अटैक नहीं होता, क्योंकि इन सब के एलडीएल 30 से 50 के बीच में रहते हैं. हमारा भी अम्बिलिकल कॉर्ड का जो एलडीएल होता है वो 30 और 50 के बीच में ही होता है. तो आपका एलडीएल कितना होना चाहिए? जितने भी लोग यहाँ हॉल में बैठे हुए हैं सबका एलडीएल 30 से 50 होना चाहिए, और सबका यहाँ कितना होगा? 125 से 150 के बीच में. आपको व्हाट इज अ नॉर्मल लेवल ऑफ एलडीएल? वी कॉल इट अम्बिलिकल लेवल ऑफ एलडीएल. Difficult to achieve, but aim should be like this. So check your LDL, check your pedometer, check your BMI. If you do these simple things, you will be better off. And I often say, लेबर रूम में प्रेगनेंसी टेस्ट करने का कोई फायदा? अरे हो गया अब तो सबका. ऐसे ही जब पेशेंट एंजियोप्लास्टी के लिए लेटा हुआ है, बाईपास के लिए लेटा हुआ है, अब क्या बात कर रहे हो?
वो टाइम निकल गए. So we have to do all these things before the patient comes for treatment at community level. We have to encourage ourselves to walk. We should walk as much as possible. Climbing stairs, walking, that should be the part of our life. और इतना रूटीनली आप पार्कों में जाइए, वॉक करिए, म्यूजिक सुनिए कि अगर किसी दिन आप किसी वजह से ना आए तो पार्क की चिड़िया आके पूछे कि यार क्या हो गया, क्यों नहीं आया आज. इतना रूटीनली घूमने जाइए. And this is Dr. Christian Bernard, who did first heart transplant in South Africa. उन्होंने कहा मैंने 150 जानें बचाई पूरे जीवन में. अगर मैं प्रिवेंटिव कार्डियोलॉजी प्रैक्टिस करता तो 15 करोड़ जान बचाता. तो प्रिवेंशन इज नॉट अ स्मॉल थिंग. डॉक्टर राहुल सिखाते हैं, हम लोग सिखाते हैं कम्युनिटी मेडिसिन में कि प्रिवेंशन इज द एसेंस. वी डोंट वांट पीपल टू फॉल सिक and then we treat them. We don't want that. We want them not to fall sick. And एक जैसे कहावत है, एक चीज इसको और करिए, चूंकि आप सब लोग डॉक्टर हैं, एम्पैथी को मत छोड़िए. पेशेंट्स के साथ स्माइलिंग रहिए, उनको टच करिए, उनको हग करिए, प्यार से बात करिए. ये आपका एक रोल है. That is what it makes. I always say there are two types of doctor. One is a good doctor. Another is a good doctor in the eyes of community. जो डॉक्टर गुड हैं in the eyes of community, they are all empathetic doctors. They are not superior doctors. They are all empathetic doctors. And ये last slide है, इसको हम नीचे से पढ़ेंगे. डॉक्टर राहुल, तुम्हारे ऑडिटोरियम में इसमें लाइटिंग कुछ ऐसे करो, इस स्लाइड पढ़ी नहीं जाती है, या तो इसको बीच में ऐसे करो. कुछ प्रॉब्लम है इसमें, वहां से you will not be able to read it. I am reading you from below. This is a Chinese slide which says inferior doctors treat the full blown disease. Heart attack हो गया, हमने इलाज कर दिया. Mediocre doctors treat the disease before evident. हमने ज़ेंथेलेस्मा देखा इनकी आंख में, कहा भाई तेरे को हार्ट की दिक्कत हो सकती है, और पकड़ दी और इलाज कर. Or superior doctors prevent the disease. So what we have to become is a superior doctors, practice community-based approaches to prevent disease so that our community is free of illness. We have to become an empathetic doctor also. Thank you very much.
That was surely a magnificent talk by the very famous Dr. Rajiv Agrawal, sir. Hope everyone present here has noted down a take-home message that to reduce the cardiovascular disease, we should inculcate in community the healthy dietary and lifestyle. Now, I would like to request Dr. Rajiv Agrawal, sir, to pick up a lucky draw coupon for the audience. Gift.
नाम आया डॉक्टर राजीव अग्रवाल. The winner is Dr. Palak Gupta, PG3, 830-7390910. Is she there? Dr. Palak Gupta, third year resident, same support. No, नहीं है तो फिर so next one.
क्या हुआ? पराग गुप्ता. It's पराग गुप्ता.
Sorry, it's Parag Gupta.
to call Dr. Saurabh sir to the wing memento and certificates to the speaker and chairpersons. Abha Gupta. The chairpersons, Dr. Abha Gupta ma'am, Dr. Rahul Bansal sir, and Dr. Amit Sharma sir.
Next up, I would like to request Dr. Sumit Kant Jha sir to introduce the next panel of chairperson and speaker to shed some light on renal transplantation.
Silence, please. Well, our next talk is a future vision for Subharti. We are very soon starting the renal transplant center here, and we are fortunate enough to have a speaker who has done so many transplants in Meerut today these days. Before that, I would like to invite our chairpersons. First of all, Dr. Snehalata Verma ma'am. She is presently working as associate professor in the Department of Medicine, Medical College Meerut. She has been member of a number of organizations and very popular figure in all the conferences. She has chaired in sessions, she has given talks, and she is very active member in the department itself for the social causes and social works. The next speaker is a neurosurgeon young neurosurgeon working in the Department of Surgery from Subharti Medical College, Dr. Shakul Prakash Kaushik. He has done his DNB from neurosurgery from Institute of Virology, Mumbai. Welcome, Dr. Shakul. And last but not the least, our own Dr. Anand Prasad, DNB nephrology, and he has got loads of degrees. I think MRCP UK from in nephrology. He is a member of European Renal Association, European Dialysis and Transplant Association. So without wasting much time, I would like to invite Snehalata ma'am to introduce our speaker.
Thank you, Dr. Sumit, for the kind words, and a very good afternoon to everyone. All the faculty members and dear students who are present here. And it's my Subharti Medicine Update. And thanks to Dr. Saurabh for organizing a short CME. And my special tribute to Dr. Mukti Bhatnagar ma'am. And it's a proud moment that Subharti Medical College has also inaugurated the museum in the memory of Dr. Mukti ma'am. So for the today's session, I would like to invite Dr. Sandeep Kumar Garg, and he is a director of the Nutima Hospital and working as a nephrologist, and he had done about 150 nephrologist renal transplantation in the pediatric age groups and ABO incompatible transplant and HLA incompatible transplant. And Dr. Sandeep Garg is also the co-doctor of LRI Medical College and had done his MD from the Abbott Medical College and MBBS from the Prayagraj Medical College. And apart from the academic and the clinical perspective, as far as personally know, Dr. Sandeep is a very kind human also. And whenever we need his help, he's really available to help us in any matter. So I welcome Dr. Sandeep for your deliberation.
Warm good afternoon from my end. Thank you, Dr. Verma ma'am, for kind words. I know Dr. Mukti when I was doing my MBBS at Prayagraj. I was very fascinated that some female doctor has joined. He did her MD from there, probably from Prayagraj only. And then I met her when I came to Meerut for practice. And I initially wanted to join Subharti, but because of some unforeseen circumstance, I couldn't do it. Subharti has grown like anything in last 2 decades. And today I'm very proud that Dr. Saurabh has asked me to deliver something which is close to my heart. I've been doing it for last 11, 12 years now. And we have around 200 odd transplant to our credit. In Utima, we have done 108 renal transplant in last 5 years. So as I am asked to tell you something about renal transplant, what all the internists should know. Because renal transplant is something which is not being done in most of the medical colleges. It is restricted to few super specialty hospitals. So we know it, but not details about it. So just a nitty-gritty about renal transplant, thanks to all my chairperson, Dr. Anand, he was very close to us. Then we went to do MRCP. I committed for doing MRCP in nephrology. Well, we all know that CKD is quite prevalent. It's around 8 to 16% in the worldwide population. We had around 2.5 lakh ESKD patients in a year. On 50,000 odd patients get dialysis, and because of free dialysis being available in various centers by the government, dialysis is now quite prevalent. But transplant, around 6,000 odd transplanting are being done in India, and we contribute around 24 transplant to 24-30 transplant per year by our center. Now this is how the transplant is being done. This is the cartoon which tells you the transplanted kidney which is being put in the right iliac fossa, and the artery is being osmosed with the right iliac artery, and vein is the right iliac vein, and ureter is osmosed with the bladder. And this is how the transplant kidneys look. Now the question is when it's required. When a patient reaches CKD5, the important point is reversibility. One shouldn't have a reversible CKD5. Sometimes people have acute and chronic kidney disease like accelerated hypertension, drugs, sepsis, dehydration can cause acute or chronic kidney disease, and sometimes patients require dialysis for a short moment of time and then they go back to their basic kidney disease. So we have to rule out reversibility in these patients before labeling them as CKD5 and ask them to go for transplant or dialysis. So acute factors has to be ruled out before asking these patients to get transplant. There shouldn't be any active infection, no active malignancy, no other organ failure. Like if a patient of chronic liver disease is there, we have to go for combined liver and kidney transplant. But as far as heart failure is concerned, if the patient is having a poor ejection fraction because of uremia, these patients reverse back to their normal EF after transplant. So this is another beauty of this method of treatment, that after doing transplant, people recover of their EF, ejection fraction, after doing a successful transplant. There should be at least an expectancy of 5 years before we ask a patient to get transplant. This is the first transplant which was done in 1954, and in India it was started in CMC Vellore, and then there was no looking back. Many centers are doing renal transplant nowadays. I have learned that Subharti is also starting renal transplant. I welcome the move under leadership of Dr. Anand probably. Now, as we all know, the dialysis doesn't replaces the whole function of the kidney. There are few functions which are not replaced by dialysis. That's why we need transplant. And the beauty of transplant is that it gives you freedom from dialysis. It has a better quality of life. You can marry, you can produce children, you can do your work. You can, if you are a CA, if you are if you are a leader like Lalu Prasad Yadav, just forget transplant. Probably you will be back into action in 2024 Lok Sabha elections. It's a better long-term survival whenever you get transplant. All functions of kidneys are replaced, and definitely it's cost effective also. Why cost effective? Because in private setup, if you get dialysis, it will cost you on 2.5 lakhs per year, and the cost of transplant will be recovered in hardly 2.5 months, 2.5 years. So it's a cost effective also, and you are back into your life, and the quality of life is quite good. There are 3 hormones like renin, erythropoietin, and vitamin D. They are not being replaced by dialysis. Renin is causing hypertension, and when you transplant a patient of ESKD, his hypertension normalizes, and it's all because the renin is not there. That bad renin is not there. Erythropoietin is also not being produced in ESKD patient, end-stage patients, and that is being replaced by erythropoietin from the outside. And whenever you transplant these patients, their anemia also improves. You don't require any EPOs for these patients, and sometimes they develop polycythemia even because of various reasons, and you need to donate their blood like regular interval. Similarly, vitamin D is not being produced whenever you have deficient kidney functions, and you need to add vitamin D to our patients. And whenever we treat this patient, our renal bone disease also improves after transplant. The long-term survival is not good on dialysis. It's around 50% in 5 years, and you need to do transplant to prolong the survival of these patients. If we talk of risk, after 100 years of transplant, the risk improves, and the death rate is quite low in patient of transplant as compared to patient dialysis. Similarly, if you talk of a marginal kidney donor or ideal kidney donor, the patient with ideal kidney donor, they survive better as compared to marginal kidney donors. If you go for preemptive transplant, this is another beauty of this renal transplant, that you need to ask our patients whom are working, like a lawyer, like a doctor. I know a doctor who was working with us. He got this disease. He got himself transplanted and back into work within span of 1 month only. So this is the beauty of this organ transplant, that if you are a working person and if you get transplant, you can get back to your work within a span of 3 months. So the survival is better whenever you go for preemptive transplant vis-a-vis after getting dialysis and then getting the transplant. So allograft survival is better if you get a preemptive transplant as compared to non-preemptive transplant. Patient survival is better when you get early kidney as compared to the patient who comes on for regular dialysis. There's cardiovascular benefit also. The patient on dialysis, they do very poor as far as cardiovascular mortality is concerned, and they die because of cardiovascular problems. Most of the patients on dialysis, they die off because of cardiovascular problem, and second most common is sepsis. And these two factors, both sepsis and cardiovascular problem, they are not seen when we get transplant. So cardiovascular disease, infectious disease, they are lesser in patients on transplant as compared to patient dialysis. If you talk of survival, the survival is better in patients with living donor as compared to disease donor. The graft and patient survival is better. Now, what we need to start a transplant program, we need a good dedicated nephrologist, we need a good urologist who can perform a transplant, we need an immunologist, a pathologist, dedicated pathologist, infectious disease specialist, and intensive care. These are the core team which are needed to start a transplant program in a center. Luckily, we have all these facilities at our center. As far as donor is concerned, legally, only first degree relative like parents, siblings, children, spouse, grandparents can donate. But the Indian law also allow friends to donate kidney, even uh, your आपका जो साथी है, आपका ड्राइवर है, even your knocker can donate kidney, but it has to be proven that it's legal. There's no money transaction in it, so it has to be legally authorized by the authorization committee, which is present in every district. Donation after brain dead is almost new to Uttar Pradesh, but you must be very encouraged that Lucknow people have started doing disease donor transplantation, and last 6-7 months they have done quite a good number of renal transplant in disease donor patient before the patient dies off and before the patient had cardiac arrest or cardiac death. The brain dead patient, the organs are harvested and you can transplant those organs. In KGMC, in SGPGI, they have done quite a good numbers of transplant in last 6 to 7 months. And this program of disease donor transplantation has now been active in UP also. In southern states like Telangana, Tamil Nadu, Karnataka, they are doing very well as far as disease donor transplantation is concerned. Although the disease donation has lesser survival as compared to living donors, but still, if you don't have a donor, disease donor helps you to get kidneys and other organs, and you can start your good quality of life. In disease donor, the kidney starts little bit later. There's avoidance of brain death stress in patient whom we get for living donor transplant, and the waiting period definitely is less with a living donor as compared to cadaveric donors. As far as kidney donor is concerned, we need to match the blood group. O is a universal donor. We all know AB is universal recipient, and in transplant for kidney at least, RS status does not affect donation. And nowadays, blood group incompatible transplant is possible, and we have done 3 ABO incompatible transplant, and last was done on 4th of January this year only. We have facility and people are doing a swab transplant also, which mitigates the requirement of blood group. And we are doing, and people are also doing a swab transplant, which also coming up as a. Now, donor evaluation has to be comprehensive because donor is a very important person in the transplant surgery, and we need not to lose a donor at least, because patient is patient, but donor is very precious to us. So every sort of test are being done before we go for transplant or donation of this patient. Immunologically, we go for HLA test and cross match and donor specific antibody also. Exclusion criteria for living donor are age less than 18 years, more than 70 years. Diabetes is debatable. We shouldn't take a long-term diabetic, but a recent diabetic being evaluated for transplantation can be taken for donation. Proteinuria more than 200 milligram is not possible. Recurrent stone disease not possible. GFR less than 60 not possible. Medical illness like chronic CLD, cardiac disease, recent malignancy not possible. Psychiatric illness, hemiplegia, paraplegia are not candidate for donation. Obesity again a contraindication. As far as contraindication to kidney transplant, any disease in which the survival is less than 5 years, like chronic heart disease, chronic liver disease, advanced lung disease, either we go for combined liver and kidney, heart and kidney, or lung and kidney transplant, or we defer the transplant in this patient. In malignancy, we defer transplant, but in RCC, we can go for transplant after 3 years of surgery. Psychiatric patients shouldn't undergo transplant. History of non-compliance, because most of the patients sometimes they lose their graft because of non-compliance with the drugs. Drug users are not candidate for transplant. HIV, hepatitis B, and hepatitis C were initially contraindication, but now people treat these patients, or we do transplant and then treat these patients and go for transplant in these patients also. Barrier to kidney transplant, donor shortage is a major problem. Awareness is another. Cost, need for lifelong immunosuppression not that difficult. Now, awareness is very much important, because sometimes I get a call that, "Bhai, mera mama ji mar gaye hain, aur kidney le le." So marne ke baad you cannot donate kidney. It has to be a brain dead person with functioning heart. In those patients, we can harvest the organ. but that's what has to be done in a center which is approved for that. You cannot just come and say मेरे मामा जी मरने वाले हो मेरी किडनी ले लो, ऐसा नहीं कर सकते आप. Transplant cost is around 6 to 15 lakhs depending on in metro non-metro cities. We around 7 lakhs of transplant cost is there at our center. Ayushman scheme में भी transplant अब आने वाला है, and probably it's a big boon for renal transplant. Immunosuppressive cost is around 5 to 10,000 depending on the patient condition, and it is subsidized in various states. Cost of dialysis is around 30 to 45,000 per month, but it's subsidized and even free in many centers. Post-transplant medication adherence is very important. 15% patient lost their graft because of non-adherence, especially the young people. They skip their medicine and get rejection as soon as they leave it. Diet and exercise is always important in every aspect of life. Similarly, patient of transplant also need to do exercise regularly to prolong their graft survival. Future xenotransplantation is coming up, and probably next 10 years we will be getting pigs for our donation. Future, you can have artificial organs. You must have seen very various videos also showing you artificial kidney which can be implanted. This is a January report of Lucknow in which people says that female jar donate करती. Definitely it's a हमारा जो सामाजिक जो हमारा ताना बाना है उसमें females ही usually donate करती हैं. Similarly, at our center we did 23 transplant last year. Around 16 females donated it. This is Selena Gomes. You must be knowing it. She had lupus, went into ASKD. Her friend Francis donated a kidney. This is Mr. Lalu Prasad Yadav, transplanted last year only. And we have around 118 transplant in last 5 years. Most of the males. This is our transplant team, and this is my hospital. Thank you very much. Thank you, Dr. Saurabh, again for calling me here and discussing a few aspects of renal transplant. Any questions? Definitely, I would like to answer those. Over to you, ma'am.
For your very nice and specific discussion on transplantation. Sir, I have one question regarding this. That mostly in convention we perform the CBC cross match or HLA type. As you mentioned that most of the states perform the relative or non-relative transplant. To you extent in non-relative transplantation is 0.6 difference, but it is neither responsible for your poor outcome of transplant. So is there genuine to perform the HLA typing prior to transplanting nowadays?
Basically, this is nephrology talk. Basically, sir, ये पूछ चाह रहे हैं कि HLA is required or not. So HLA is not at all required for renal transplant at least, and we can do transplant even without HLA match also. So that is your answer, probably, no?
But most of the studies they mention that if you the good HLA typing, so graft survival is better than HLA typing.
Definitely. Well done.
But it is not related to the DSA antibody rather than the non-DSA antibody which is responsible for your chronic graft damage.
As far as donor-specific antibodies are there, they are definitely, we can measure them. And there are few non-DSA, like non-donor-specific antibodies are there, which are not measurable. And those cause loss of graft in some patients. देखिए जो हम बात कर रहे हैं तो थोड़ा सा nephrology talk है, but what we need to understand is that HLA match is not required for kidney transplant, and there are few donor-specific antibodies which we do measure before transplant, and the antibodies, if present in the higher levels, we have to do immunosuppressive jugglery like plasmapheresis, rituximab, immunoadoption, and IVIG and plasmapheresis before going for transplant. And the survival is poor in these patients who are getting high DSA titers or non-HLA match. But still, as far as quality of life is concerned, as compared to dialysis, the quality is quite good in patients who receive transplant. So definitely transplant is a boon as far as ESKD patients are concerned. In few conditions, we defer transplant also, like there are few disease like febrile neuropathy or hematocrit neuropathy, or patients of amyloid also we defer transplant because there are good number of recurrent rate after transplant in the graft kidney. So there are only few conditions in which we defer transplant. Otherwise, most of the patients can be taken up for transplant, and the survival of the graft varies depending on the graft which we take and the donor which we take.
Thank you everyone for the presence. I would like Dr. Saurabh Singhal sir to please give the mementos and certificates to the chairpersons and speakers. Dr. Snehalata madam. Dr. Anand, Dr. Shukul, and finally the speaker, Dr. Sandeep Joshi.
एक जब तक प्रेजेंटेशन सेरेमनी हो रही है, मुझे 4-5 बातें बतानी है रिगार्डिंग क्लोथराइडोन. डॉक्टर सौरभ सिंघल ने मुझे कहा था कि क्लोथराइडोन के बारे में 4-5 बताने के लिए बातें. So it's a thiazide group of diuretic which we don't use in patients of advancing failure. After the GFR falls less than 30 ml, we don't use thiazide diuretic for control of hypertension. But what we have seen in the latest study, which was presented by, it was published in NEJM last year only, by Mr. What that study showed that in various aspects of treatment in ESKD patients, the chlorthalidone drug, which was not being used as an antihypertensive after the GFR falls less than 30, we can use these drugs because chlorthalidone specifically causes less of albuminuria, better control of hypertension, and it has shown various effects which were not known earlier because this drug was not used in these patients. Now there is a paradigm shift of treating these patients less than 30 ml GFR with chlorthalidone, and now it's recommended to be used in these patients whenever we need to use this drug. There are two beautiful trials. One is CLICK trial and is LR trial, and both tells you that we can use chlorthalidone in patients less than 30 ml GFR also. Thank you very much.
Neurology has never been a bed of roses for me. I have always found myself struggling with various tracts, signs, reflexes, and whatnot. Hope all of my scuffle would now end. With the next talk, I would like to request Dr. Sumit Kant Jha sir to invite the next panel of chairpersons and speaker, Dr. Arun Sharma sir, who would be delivering a talk on approach to a case of neurology.
It's my pleasure to invite the backbone of neuroscience department of Subharti Medical College, two very hardworking people, Dr. Vishal as chairperson for the next talk. Dr. Vishal has done MBBS and MD Medicine from IGMC Shimla and DM Neurology from HIMAS New Delhi. Presently, he heads the neurology department, neuromedicine, neurophysician department of the Subharti Medical College. And the next chairperson is Dr. Abhinav Bansal, a very young and enthusiastic person, always helpful, always busy. and he is heading the neurosurgery department. Without wasting much time, I would like to call Dr. Vishal to introduce our next speaker, and I am very obliged for him, for he has waited for so long for his turn. Over to Dr. Vishal.
Thank you, Vishal. Thanks, Dr. Saurabh, for asking me to be part of this CME. पहली बात तो बिना न्यूरोलॉजी के एमडी पास नहीं हो सकता. मेन केस होता है और है बड़ी सिंपल. हवा बहुत बनाया जाता है इसका. जरूरी है कि न्यूरोएनाटॉमी के बिना न्यूरोलॉजी नहीं आ सकती. तो बेसिक्स आपको बड़े क्लियर करने पड़ेंगे. यदि बेसिक्स क्लियर नहीं है तो न्यूरोलॉजी बिल्कुल हवा नहीं लगेगी. क्या हुआ? न्यूरल एक्सिस की जहां तक बात करते हैं हम, मसल स्पिंडल, मसल, न्यूरोमस्कुलर जंक्शन, पेरिफेरल नर्व, एंटीऑन सेल, सेंसिटिव nerve endings, then ventral dorsal roots, spinal cord, brainstem, basal ganglia, intercapsule, and cortex. We just lower down to up. We have to read each and everything. This is a muscle spindle, well connected to the spinal cord through peripheral nerves. Then neuromuscular junction, then peripheral nerve having dorsal root ganglion, all ramus, making trunk and cords. Then various plexus, brachial, lumbar plexus, spinal cord, various laminas, rex lamina, various distribution in the gray matter, from dorsum to ventral, as where the sensory inputs comes and motor outputs out. Then various tracts in the spinal cord. This is the medulla. This neuroanatomy is so important. Yes, where the tract goes, where the lesion is, and what are the presentation is. If you do not know this, you start cramming. रट के न्यूरोलॉजी नहीं समझी जा सकती. यदि आपको बेसिक न्यूरोएनाटॉमी क्लियर है, कोई प्रॉब्लम नहीं है. There is a pons, midbrain and इंटरनल कैप्सूल, मोटर ट्रैक्ट्स. अब मोटर ट्रैक्ट्स कैसे बना, कहां से आया, कैसे इंटरनल कैप्सूल से आया, कैसे मिड ब्रेन में आया, और कैसे पॉन्स में, फिर कैसे मेडुला में, और कैसे एंटीऑन सेल पे आके डिस्ट्रीब्यूट हुआ. तो ये सब पूरा पाथवे यदि क्लियर नहीं होगा तो लीजन्स वेरियस लेवल पर होंगे तो आप नहीं समझ पाएंगे. सिंड्रोम्स भी उसी स्टाइल से डेवलप होंगे उसके. दे आर पिरामिडल ट्रैक्ट्स एंड एक्स्ट्रा पिरामिडल. दो तरह की चीज होती है, बड़ी कंफ्यूजिंग सी लगती है कि पिरामिडल एक्स्ट्रा पिरामिडल क्या हो गया. पिरामिडल सीधा वहां से कॉर्टेक्स आया, सीधा आपका एंटीऑन सेल पर आ रहा है, पिरामिडल. और इसके अलावा जो भी घूम फिर के आया उसके अलावा वो एक्स्ट्रा पिरामिडल. This it means there are corticospinal tract and corticobulbar tracts जो डायरेक्ट न्यूक्लियस पे आ रहे हैं और वहां से पेरिफेरल को जा रहे हैं, तो वो पिरामिडल है. इसके अलावा एक्स्ट्रा पिरामिडल सारे रूब्रोस्पाइनल, रेटिकुलोस्पाइनल, वेस्टिबुलोस्पाइनल, टेक्टोस्पाइनल, एवरीथिंग इज एक्स्ट्रा पिरामिडल. सारे के सारे जो पिरामिडल ट्रैक्ट हैं वो टर्मिनेट होते हैं आइदर एंटीहॉर्न सेल या आपके क्रेनियल नर्व न्यूक्लियाई पे, जबकि एक्स्ट्रा पिरामिडल सेल्स बीच में इन बिटवीन, शुरुआत तो उनकी कॉर्टेक्स से होगी, इन बिटवीन वो ब्रेन स्टेम आएंगे रेटिकुलर फॉर्मेशन में, और वहां से वो फिर नए ट्रैक बनाएंगे अपने, और वो नीचे जाके वो कहां टर्मिनेट होते हैं? इन द इंटरनेशनल न्यूरॉन्स। पिरामिडल ट्रैक एक्साइटेटरी होता है, एक्स्ट्रा पिरामिडल इनहिबिटरी होता है, दे इनहिबिट। और इन दोनों की जरूरत बिल्कुल इसलिए है कि एक गाड़ी आपको दे दी जाए चलाने के लिए और उसमें ब्रेक ना हो, तो ब्रेक्स बहुत जरूरी है। एक्स्ट्रा पिरामिडल ब्रेक लगाता है हमेशा, जब भी आप कोई काम करते हैं तो ब्रेक जरूरी होते हैं। दिस इज सेंसरी ट्रैक्ट। सेंसरी ट्रैक्ट में भी आपको जितने भी सारे आपके न्यूरॉन है सबके डॉर्सल गैंग्लियन में होते हैं, उसका पेरिफेरल पार्ट और सेंट्रल पार्ट, फर्स्ट ऑर्डर न्यूरॉन। पेरिफेरल पार्ट जो भी जाता है पेरिफेरी में जाके वो सेंसरी एंडिंग्स बनाता है। इट मे बी फॉर dorsal column, it may be for anterolateral column. Dorsal column means position senses and anterolateral means pain, temperature, these senses. तो दोनों के ट्रैक्ट आके वहां जाते हैं और दोनों सेपरेट फिर चलते हैं ऊपर हमारे पास। अभी हम जब बात करते हैं लीजन्स की, स्पाइनल कॉर्ड पे क्या लीजन होगा, ऊपर क्या लीजन्स होंगे, तो डिपेंड करेगा कि हमारे लीजन्स कहां हुए, कॉर्ड में किस जगह पे हैं। हम जैसे अभी फर्स्ट ऑर्डर न्यूरॉन यहां पे होके उसके बाद सेकंड ऑर्डर कहां होता है इसका, डॉर्सल कॉलम का कहां होगा? दिस इज अ टू वे टीचिंग। पीजीज कैन इंटरेक्ट। सेकंड ऑर्डर न्यूरॉन कहां होता है डॉर्सल कॉलम के लिए? न्यूक्लियस ग्रेसिलिस एंड क्यूनेटस, एंड इट इज इन द मेडुला। और जबकि वहां उसका क्या होता है स्पाइनोथैलेमिक का, दिस इज एंटरलेटरल स्पाइनल कॉलम का। जो आपके पेन एंड टेम्परेचर के हैं उनका सेकंड ऑर्डर कहां होता है? सेकंड ऑर्डर कहां न्यूरॉन उनका? दैट इज इन सबस्टेंशिया जिलेटिनोजा, सबस्टेंशिया जिलेटिनोजा, रेक्स लेमाइना 1, 3 and 4। तो व्हेन जब तक अब ये क्लियर नहीं है अब कैसे फिर करेंगे फिर? अब हम ऊपर जाते हैं, ये डायरेक्ट स्पाइनोथैलेमिक मींस डायरेक्ट थैलेमस में चला जाता है और वहां पे फिर ग्रेसिलस क्यूनेटस से थैलेमस में जाता है। और उसके बाद क्या कहते हैं, ग्रेसिलस क्यूनेटस से जो थैलेमस में जाता है उस ट्रैक्ट का नाम क्या है? ग्रेसिलस एंड क्यूनेटस से जब थैलेमस में जाता है नाम उसका होता है ना कोई ट्रैक्ट का, क्या होता है? पर्पस मेरा सिर्फ यही था आज आने का पर्पस, और कुछ नहीं था। दिस इज मीडियल लेम्निस्कस and this terminates into VPL and VPM of thalamus and then thalamocortical radiations for the localization। जो आपकी अभी स्पाइनोथैलेमिक है रेक्स लेमाइना में वो बन गया था वहीं पे डॉर्सल कॉलम पे, तो वो अब क्रॉस कर जाते हैं उसी लेवल पे। जो पेन एंड टेम्परेचर वाले होते हैं वो उसी लेवल पे क्रॉस करते हैं, सेम लेवल जिस पे एंटर करते हैं, एक या दो सेगमेंट ऊपर नीचे क्रॉस कर जाते हैं और लेटरल क्रॉस करके दूसरी साइड में चले जाते हैं और वहां से वो ट्रैक ऊपर चला जाता है, लेटर स्पाइनोथैलेमिक ट्रैक, एंड देन टर्मिनेट्स अगेन इन थैलेमस। तो बोथ वेज, पोस्टर कॉलम सेंसेशंस एंड लेटर कॉलम सेंसेशंस, both terminate in the thalamus, but crossing is different. And for the same type of crossing, like in hemichord section syndrome, hemisection syndrome, you have read it? Hemisection syndrome. Hemisection syndrome symptoms are totally different. But if you know anatomy, neuroanatomy, no problem. You don't have to read, don't have to cram any sign and symptoms. Everything you know by heart. Again, call the medulla, where the sensory crossing occurs. Lower medulla, upper medulla. Where the motor crossing occurs. Sensory is also crossed. Curators and gracilis. Motor is also crossed in the pyramidal. The downward tract and upward tract. Where they cross. Sensory crosses up, motor crosses down. Then again, this we have span helping and all this. Yes. This one is, yes, complete. This same crossing is there, then this becomes pyramidal tract, anterior spinal motor tract, and they terminates in the anterior cell in the particular levels. Now comes the dermatomes. What is dermatome? Dermatome. It is the area of the skin supplied by a particular root. This you have to learn by heart. क्योंकि जब भी आपको लोकलाइजेशन की जरूरत पड़ेगी, डर्मेटोम जरूर पता होने चाहिए. बिना डर्मेटोम के काम नहीं चलेगा. Where is the C1 dermatome then? From PGs, where is the C1 dermatome? From PGs. There is no C1 dermatome. सर C1 dermatome नहीं होता. Dermatome C2 से स्टार्ट होता है. अच्छा, सर्वाइकल में आपको वर्टिब्रा तो 7 होती हैं, स्पाइनल 8 होती हैं. क्यों? C7 ही होता है, वर्टिब्रा तो 7 ही है. नर्व क्यों 8 हो गई? कोई अपना इंटरेक्शन करेगा? नहीं, वो होती है, मैं बताया सही लो. C1 का जो डर्मेटोमा कहां चला जाता है? C1 कहां चली जाती है? व्हाट फॉर्म C1? अंसा सर्वाइकलिस नाम सुना है? देन यस, 2 यहां होता है, 3 यहां, 4 यहां पे, 5 इधर. आराम से जस्ट यू कैन राइट. 6, 7 मिडिल फिंगर. ठीक है. 8 एंड T1 इधर हो जाते हैं. T1. तो ये आपको बेसिकली ऊपर से नीचे तक बाय हार्ट लर्न करना है. लोकलाइजेशन के बिना नहीं हो सकता है. देन इट्स सेम फॉर लोअर लिम्स. कुटेनस नर्व्स आल्सो इंपॉर्टेंट. अब यहां तो बात आ गई, ठीक है, हमने रूट लेवल पे बता दिया, लेकिन यदि इंडिविजुअल नर्व इंजरी है तो कैसे पता लगाएंगे? उसके लिए आपको क्यूटेनस नर्व सप्लाई पता होनी चाहिए. सुप्रास्कैपुलर, डेल्टॉइड, लोअर, दिस इज later cutaneous nerve of arm, forearm, medial cutaneous nerve, forearm, arm, then radial nerve, this medial ulnar, sensories. तो ये इनके डिस्ट्रीब्यूशंस क्लियर कट होने चाहिए हमें. इसमें कंफ्यूजन होगा तो सेम फॉर लोअर लिम्स, क्योंकि इंडिविजुअल नर्व इंजरी भी हो सकती है. अभी आपको जैसे इडियोपैथिक ब्रेकियल प्लेक्साइटिस, कभी केस देखा कोई? पेशेंट को पेन होता है, 5-7 दिन पेन रहता है, उसका खाना बंद कर देता है. सेंसरी लॉस कहां मिलता है? इडियोपैथिक ब्रेकियल प्लेक्साइटिस. जब अंदर घूमती है एट द सर्जिकल नेक ऑफ ह्यूमरस, वहां से लेटरल ब्रांच देती है, डेल्टॉइड को क्रॉस करती है, नीचे डिसेंड करती है, दैट इज कॉल्ड एज अपर लेटरल कुटेनियस नर्व ऑफ आर्म। बट डेल्टॉइड के आधे हिस्से से नीचे सप्लाई करती है वो, और वहां सेंसरी लॉस मिलता है इडियोपैथिक ब्रेकियल प्लेक्साइटिस में। जब भी कभी ऐसा हो कि पेशेंट को पेन हुआ और उठना बंद हो गया, यहां की वेस्टिंग मिलती है डेल्टॉइड की, सुप्रास्कैपुलर इसकी वेस्टिंग मिल सकती है, लेकिन सेंसरी लॉस इसका यहां मिलेगा। तो यदि आपको क्लियर कट पता है चीजें कहां मिलना है, क्या चीज मिलनी है, तो वहीं देखोगे सीधी डायग्नोसिस सामने मिल गई, कुछ नहीं करा आपने। देन रिफ्लेक्सेस, सेम डीप टेंडर रिफ्लेक्सेस हम देखते हैं, इनके हमको रूट वैल्यूज पता होनी चाहिए। जो रिफ्लेक्स एब्सेंट होगा तभी तो रूट वैल्यूज के हिसाब से आप लोकलाइज कर पाओगे। बाइसेप्स, ट्राइसेप्स, ब्रिगेडियस, क्वाड्रिसेप्स वगैरह, बाइसेप्स का C5 C6 है, जैसे ट्राइसेप्स C7 8, ब्रिगेडियस C5 6, क्वाड्रिसेप्स पटेलर L2 2 3 4, अकेलिस L5 to S2. Superficial same for Babinski L4 to S2, abdominals, upper abdominals T10 to T10 and lower T10 to T12, cremastric L1 L2. ये तो सुपरफिशियल डीप रिफ्लेक्सेस की बात होगी। अब आप मोटर मायोटोन्स, क्या मूवमेंट नहीं हो रहा तो कौन सा रूट गड़बड़ हो रहा होगा। C1 क्या काम करता है, अपर सर्वाइकल फ्लेक्शन, C2 अपर सर्वाइकल एक्सटेंशन, C3 सर्वाइकल लेटरल फ्लेक्शन, C4 शोल्डर गर्डल एलिवेशन, C5 shoulder abduction, and then elbow flexion. This is the whole of list. You should know it by heart. This is a spinal cord and vertebral correlation. आपको पता है कॉर्ड पहले एंड हो जाती है, रूट्स नीचे तक निकलती रहती हैं, तो दोनों में कोरिलेशन जरूरत है। यदि आपको स्पाइनल लेवल पे कोई आपको लीजन मिल रहा है और आपको वर्टिब्रा पे पिंच करना है कि हाँ कहां जाकर देखना कहां लीजन हो सकता है, तो आपको दोनों के कोरिलेशंस पता होने चाहिए। बुक्स में क्लियर कट सब लिखा हुआ है, आराम से पढ़ सकते हो। ठीक है, वैसे बताओ कि कॉर्ड जहां एंड हो जाती है और कॉर्ड की जो कवरिंग्स हैं कहां तक जाती हैं, इट इज कॉल्ड एज फाइलम टर्मिनल। कहां तक जाती है, S2. This is vascular supply, you know very well. अब डायग्नोसिस की बात आती है, डायग्नोसिस करना क्या है। पहले तो कभी पीजी एग्जाम में कभी डायग्नोसिस मत बता देना, never tell a diagnosis, always give a approach to the diagnosis. आप एक एक स्टेप चलते चले जाइए और जहां जाके आप रुक जाइए, डिफरेंशियल डायग्नोसिस में रुकिएगा। मेरे हिसाब से पॉसिबली ये डायग्नोसिस हो सकती है। यदि आपको डायग्नोसिस पता भी है और डायग्नोसिस आपने बता दी, आप फंस जाओगे बुरी तरह से। अब डिसऑर्डर्स क्या क्या हो सकते हैं। पहले तो डायग्नोसिस में प्लान मैंने जो पर्सनल करता हूं, ऑब्जर्वेशन, हिस्ट्री, एग्जामिनेशन, प्रोविजनल सिंड्रोमिक डायग्नोसिस, डिफरेंशियल डायग्नोसिस, प्लान ऑफ इन्वेस्टिगेशन, डेफिनेट डायग्नोसिस, ट्रीटमेंट प्लान। ऑब्जर्वेशन लोग बड़ा लाइटली लेते हैं, मेरा पर्सनल मानना यह है, ओपीडी में आप सीधे पेशेंट को फेस करते हुए बैठिए। पेशेंट जब तक आपके पास आता है, आपकी 30% डायग्नोसिस बन जानी चाहिए। 30% डायग्नोसिस, हिस्ट्री के बाद 20% और, एग्जामिनेशन के बाद 10-15%, इन्वेस्टिगेशन 10-15%, बाकी 10-5% बनती नहीं है। तो ऑब्जर्वेशन इज वेरी इंपॉर्टेंट। जितने भी डिसऑर्डर्स हो सकते हैं सिम्टम्स जो आपके पास ब्रेन पूरा न्यूरल एक्सेस है, इसमें दो चीजें हो सकती हैं, या तो पॉजिटिव वर्क कर सकता है, नेगेटिव वर्क कर सकता है। ब्रेन में पॉजिटिव वर्क क्या क्या होता है? फ्रॉम पीजीज, ब्रेन में पॉजिटिव वर्क क्या क्या हो सकता है? ब्रेन पॉजिटिव वर्क करे, और एक डिजीज तो है एपिलेप्सी भाई। ब्रेन का कोई भी पोर्शन यदि पॉजिटिव वर्क करेगा मीन्स ओवर फंक्शन। एपिलेप्सी इज नॉट गुड एग्जांपल। नेगेटिव, नेगेटिव तो बहुत सारे हैं, सारे पैरालिसिस होते हैं, सारे नेगेटिव ही है। देन इंटरमिटेंट एपिसोडिक, जैसे एपिसोडिक सीजर्स हो सकते हैं, पीरियोडिक पैरालिसिस हो सकती हैं, डिस्टोनियाज हो सकते हैं, प्राइमरी, सेकेंडरी, साइकोजेनिक, नॉन ऑर्गेनिक, सभी तरह के हो सकते हैं। ठीक है। ऑब्जर्वेशन, ऑब्जर्वेशन कैसे करने? पेशेंट इंडिपेंडेंट चलता हुआ आया, सहारे से आया, कॉन्शियस है, अनकॉन्शियस है, सबकी अलग अलग ऑब्जर्वेशन हो सकती है। एक पेशेंट आपके इमरजेंसी में आया, हर 8 से 10 सेकंड पे उसको जर्क आ रहा है, गफलत में है, हर 8 से 10 सेकंड पे जर्क आ रहा है। पेशेंट की एज है 12 साल। डायग्नोसिस ऑल्टर्ड मेंटल स्टेट में हर 8-10 सेकंड पे उसको जर्क आ जा रहा है। तीमारदार कह रहे हैं कि सब पहले तो ठीक था, कुछ दिन पहले, अभी 5-6 महीने से डाउन हुआ है। पढ़ता लिखता था पहले, कोई क्लू? मैं इसलिए कह रहा हूं, जस्ट ऑब्जर्वेशन है आपकी वहां पे। ये तो बाद में पूछा आपने। असिस्टेंट आ रहा है, एक तो इंडिपेंडेंट, एक तो ये तो इमरजेंसी में आया, असिस्टेंट आ रहा है, पकड़ा कर लेकर आ रहे हैं, राइस ट्यूब डली हुई है, मुंह से राल निकल रही है, एक्यूट ऑनसेट का हुआ है। पहले वाला भाई हर 6-8 सेकंड को हो रहा है, पीरियडिक है, कोई भी एबनॉर्मलिटी है, ऑल्टर्ड मेंटल स्टेट है, पहले सब कुछ ठीक था, अभी डिक्लाइन ऑफ फंक्शंस है। व्हाई नॉट इट इज एसएसपी, सब एक्यूट स्क्लेरोसिस पेनिसिलिटिस। आपको थॉट देना पड़ेगा अपना, क्या है हर स्टेज पे। ऐसे ही वो चलता हुआ है, असिस्टेड है, नाक में ट्यूब डली हुई, इसका मतलब एक चीज क्या है, नाक में ट्यूब डली हुई है, स्वोलिंग प्रॉब्लम है, पकड़ के ला रहे हैं, इसका मतलब अटेक्सिया है उसे, एक्यूट ऑनसेट का है, बोलने में परेशानी हो रही है, क्या हो सकता है? नहीं, सोचना नहीं चाह रहे। क्या क्या सोच सकते हो? हेड में बाल्ड है, हैचेक फेस है, फेशियल इंजरीज है। अच्छा, एक ऐसी आपको पेशेंट आता है, उसे दौरे पड़ रहे हैं, दौरे सीजर होते हैं, और उसके सर में चोट लगी है, गुल्ले से निकले पड़े हैं बहुत ज्यादा। किस टाइप का सीजर होगा उसे? सारे माइक्रोनिक सीजर वाले सर फोड़ते रहते हैं अपना। Drooping eyelids, deviation face, spontaneous movements, abnormalities, tremors, neurocutaneous syndromes, you can see, gum hypertrophies. ये देखो क्या है, क्या है भाई? बहुत क्लासिकल। गंजा इंसान है, कुल्हाड़ी जैसा मुंह है, मायोटॉन डिस्ट्रोफी, देखो ओपीडी में आपके पास आया, आपने बैठा, आपके पास बैठा और आपने तुरंत उससे पूछा कितने साल से दौरे बढ़ते हैं तुझे? जब तक ये नहीं पूछोगे उसे कैसे समझ में आएगा कि आप डॉक्टर साहब को कुछ पता है? क्या है बताओ? इसे पढ़ने चक्कर में चलो, अगर मिल भी जाते हो कोई बात नहीं, अब देखो तो दोनों को देख लो आराम से, फिर बता दो। देखे होंगे भाई, पेशेंट देखे होंगे, ट्यूबरस स्क्लेरोसिस, ये भी देखा होगा, लिखा भी हुआ है यार, स्ट्रेस वेबर। ये क्या है? इसलिए सब कहा है कि हमारे न्यूरोलॉजी की जो बीमारियां हैं ना बाहर दिखती हैं। कार्डियोलॉजी में किसी को एमआई हो और इजेक्शन फ्रैक्शन 60 से घट के 30 आ जाए, इंसान घूमता फिरता घर चला जाता, कुछ नहीं कहता किसी से। हमारे यहाँ यदि उसको जरा सा भी साहब सब तो ठीक हो गया, हाथ नहीं चल रहा है अभी तो हर चीज सब बाकी तो ठीक है, आवाज में लड़खड़ाहट है, चेहरा टेढ़ा है अभी, तो हर चीज बाहर दिखती है। कुछ आइडिया है इसका? फेशियल हेमियोट्रोफी, ये देखो पहले वाला क्या हो सकता है? इधर से पहला, दूसरा, क्यों नहीं मिल रहा? अरे माइस्थीनिया थर्ड नर्व पैल्सी है भाई, ये बहुत इंटरेस्टिंग है। दोनों रिस्ट ड्रॉप है, देख रहे हो, दोनों प्रॉब्लम है। पहले वाले ग्रुप में दूसरे वाले में क्या फर्क है? रिस्ट ड्रॉप यहां भी है, उधर भी है, ऐसे इधर रेडियल नर्व है, उधर पोस्टीरियर इंट्रोशियस, पोस्टीरियर इंट्रोशियस। पोस्टीरियर इंट्रोशियस में रिस्ट ड्रॉप नहीं करेगा, रिस्ट यही रहेगा, उंगली ड्रॉप करेगी बस। ये तो देखे होगा। इधर वाला क्या है? पहले वाला टंग एट्रोफिक फेसिकुलेशंस बहुत बढ़िया मोटे मोटे से ऊपर दिख रहे हैं। और दूसरे वाला क्या है? टंग एक तरफ घूम गई। अच्छा बता दे, 12th नर्व पैल्सी है, चलो छोड़ो 12th में, दूसरे वाले में 12th नर्व पैल्सी में टंग एक तरफ क्यों घूमती है? हाइपोग्लॉसल में टंग एक तरफ क्यों घूमती है? भाई देखो, पीजी होके ऐसा नहीं चुप बैठ सकते हो। टंग क्यों घूम जाती है भाई? 12th में टंग एक तरफ क्यों घूम जाती है? बोलो, कौन सी? जीनियोग्लॉसस। ये बताओ, पहले वाला क्या? साइन है ये। मीडिया नर्व का पढ़ना, ठीक है। दूसरा वाला इंट्रिंसिक मसल्स क्लॉ हैंड है। अगले वाले क्लॉ हैंड देखो दोनों, एक मीडियन का क्लॉ हैंड है, एक रेडियल अल्लर का क्लॉ हैंड है। ये तो बड़े आराम से बता दोगे। कान में क्या है? कान में क्या है? कान में हर्पेटिक। ये क्या है पहले वाला? ये तो दोनों ही बता दो फटाफट, स्पॉट डायग्नोसिस में कुछ नहीं है। पेरोडियल मस्कुलर एट्रोफी, दूसरा फेशियो स्कैपुलोह्यूमरल, पीछे स्कैपुलोह्यूमरल, पीछे पूरा सूख गया। अब पर्पस क्या है कि जो हम अभी जो इन्वेस्टिगेशंस की बात कर रहे थे, जो प्रेजेंट की डायग्नोसिस की, तो प्रोविजनल डायग्नोसिस आपको ऑब्जर्वेशन के लेवल पे पहली स्टेज बना देनी चाहिए, पहली प्रोविजनल डायग्नोसिस। उसके बाद आएंगे हम हिस्ट्री। हिस्ट्री पे सबसे पहले उसने पूछा आपका नाम बताओ। नाम में ही बहुत सारी चीजें पता समझ में आ जाती है। कॉम्प्रिहेंशन कैसा है, अफेजिया है, डिसार्थ्रिया है, डिस्फोनिया है, ठीक है। और चलता हुआ पेशेंट आया, गेट आपने देख लिया, तो इतनी सारी डायग्नोसिस फिर बन गई। कुछ ही जरूरत होगी, कोई एग्जामिन नहीं किया हमने, सिर्फ देखते हुए इतनी डायग्नोसिस बन गई। अब हिस्ट्री में ले लेंगे हम, सर्टन है, अक्यूट है, सब अक्यूट है, क्रॉनिक है, प्रोग्रेसिव, रिग्रेसिव, फ्लक्चुएटिंग, और कितने ड्यूरेशन का है, पास्ट सिमिलर एपिसोड है, हुआ है फैमिली में, पर्सनल है, ट्रीटमेंट हिस्ट्री है, ये सब ले लिया हमने। फिर प्रोविजनल डायग्नोसिस इस स्टेज बना लीजिए। इतनी हिस्ट्री लेने के बाद में प्लस आपने जो व्यू था उसके बेस पर फिर प्रोविजनल बना लीजिए स्टेज 2 की। उसके बाद आप एग्जामिनेशन कर लीजिए, रूटीन न्यूरोकोडल सिंड्रोम, फ्रॉस्टर, डिफॉर्मिटी, स्पाइन, टीपीआर, पेन स्कोर देख लिए। फिर एमएमएससी आपने हायर मेंटल फंक्शन में एमएमएससी देख लिया। एग्नोजिया, व्हाट इज एग्नोजिया? तुम्हारे काम की चीज है। व्हाट इज एग्नोजिया? व्हाट इज एग्नोजिया? व्हाट इज एप्रेक्सिया? हाँ जी, ऐसा मत करो भाई। एमएमएससी सबको रटा हुआ हो, कोई बात नहीं है। व्हाट इज एग्नोजिया? व्हाट इज एप्रेक्सिया? सिंपल चीज है जो पूछी जाएंगे, ऐसा नहीं कोई बच नहीं जाओगे इन चीजों से। एग्नोजिया इज इनेबिलिटी टू परसीव, इनेबिलिटी टू परसीव ए लर्नड एक्टिविटी। जो भी आपने सेंसेशन है, आपने पहले देखा हुआ है, उसको आप परसीव नहीं कर पा रहे हो, एग्नोजिया। जैसे कि बहुत सारे एग्नोजियाज हो सकते हैं, विजुअल एग्नोजिया, ऑडिटरी एग्नोजिया, सेंसरी एग्नोजियाज, बाकी पोस्चरल सेंसेस के मतलब आपके टच के सेंसेशन, आपने कुछ चीजें दी कुछ हाथ में, उसके बाद आपने कहा फील करके बताओ क्या है। उसने जब पहले से कोई फील ही नहीं की हो, नहीं बता पाएगा। लेकिन हाँ, यदि आपने पहले से देखा हुआ है कोई चीज, उसको परसीव कर रहे हो, बता पाओगे आप। जो वर्बल एग्नोजियाज होते हैं, मतलब सुनने वाले, बेसिकली राइट और लेफ्ट के टेम्पोरल लोब में क्या फर्क है, कुछ पता है? राइट का टेम्पोरल लोब किसी का खराब हो गया, लेफ्ट का खराब हो गया। एक वर्बल होता है, एक नॉन वर्बल होता है। नहीं पता। लेफ्ट वाला जो होता है वो वर्बल होता है और राइट वाला नॉन वर्बल होता है। कहने का मेरा मतलब है, किसी को आपने बोला और बोल के समझ नहीं पा रहा, दैट मीन्स वर्बल एग्नोजिया है। उसने कहा वैसे तो नहीं समझ में आया, लेकिन जैसे उस गाने की ट्यून बजी उसने बता दिया ये होता है वो वाला गाना है। नॉन वर्बल म्यूजिकल एग्नोजियाज वो राइट से होते हैं। ऐसे ही आपको विजुअल एग्नोसिया जो होते हैं वो हेलुसिनेशंस के फॉर्म में आते हैं। जैसे मुझे तो वो आग जलती हुई दिख रही है, मकान बना हुआ दिख रहा है। हेलुसिनेशंस दो तरह के होते हैं, फॉर्म्ड हेलुसिनेशंस और अनफॉर्म्ड हेलुसिनेशंस। अनफॉर्म्ड कहां मिलते हैं? अनफॉर्म्ड हेलुसिनेशंस ऑक्सीपिटल लोब, फॉर्म्ड हेलुसिनेशंस टेम्पोरल लोब। अनफॉर्म्ड कैसे होते हैं? जैसे आग का गोला दिख रहा है बस। टेम्पोरल लोब में जब चले जाओगे सब कुछ दिखेगा, मकान भी दिखेगा, कमरे भी दिखेंगे, सामान भी दिखेगा रखा हुआ, सब कुछ दिखेगा, एवरीथिंग फॉर्म्ड टेम्पोरल लोब में। ऐसे ही आपको फ्रंटल लोब टेस्ट क्या क्या करते हो हायर मेंटल फंक्शंस में? प्री फ्रंटल, फ्रंटल लोब में क्या टेस्ट करते हो? करते हो नहीं करते हो कुछ भी? जजमेंट, प्लानिंग एंड 3 स्टेज सीक्वेंशियल टास्क करते नहीं हो। अच्छा, एब्रोसिया तो हो गया। एप्रेक्सिया क्या होता है? एप्रेक्सिया इडिएशनल, इडियोमोटर, ड्रेसिंग और कंस्ट्रक्शनल एप्रेक्सिया, 4 होते हैं ना? नहीं पढ़े? डिफाइन तो कर दो। डेफिनेशन, डेफिनेशन क्या है एप्रेक्सिया की? भाई पढ़ते नहीं हो आप, कैसे काम चलेगा फिर? गेट आपको सारे पता ही है, उसमें कोई बात ही नहीं। हेमिप्लीजिक, पैराप्लीजिक, डायप्लीजिक, वेडलिंग, हाई स्टेपेज, स्टैंपिंग, एटेल्जिक और वाइड स्पेटस। हेमिप्लीजिक गेट में पैर क्यों घुमाता है? हेमिप्लीजिक गेट में पैर क्यों घुमाता है पेशेंट? नहीं, हाई स्टेपिंग गेट और स्टैंपिंग गेट दोनों में क्या फर्क है? हाई स्टेपिंग और स्टैंपिंग गेट, फटाफट बता दो। स्टैंपिंग तो वहां से लिया था जो डाकखाने मोहर लगाते हैं, धम 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 वाला। अरे फुट ड्रॉप वाले में हाई स्टेपेज गेट मिलेगा, और जिसने पोस्टर कॉलम सेंसरी लॉस होगा उसमें उसे पता ही नहीं, जॉइंट सेंसेशन नहीं है उसके। सिंपल चीज है भाई। वाइड बेस अटैक्सिक सेरिबेलम में मिलेगा, डायप्लीजिक हेरिडेटरी स्पास्टिक पैराप्लीजिया मिलेगा। एक मिडिल कॉलेज में अभी तो नहीं है, हर एग्जाम में आता था वो, HSP था, कुक था, बिल्कुल इस तरह चलता था। डायप्लीजिक, पैराप्लीजिक, बाकी सब आपको पता ही है। स्पीच का डेफिनेशन पता है? स्पीच कैसे डिवाइड करते हो? ब्रोकास, वर्नेक्स, कंडक्शन, ट्रांसकॉर्टिकल सेंसरी, ट्रांसकॉर्टिकल मोटर। पेरिसिलियन हैं 3 स्पीच डिसऑर्डर्स, ब्रोकास वाला, वर्नेक्स वाला और कंडक्शन वाला। तीनों को एक जगह कर दोगे, रिपीटेशन नहीं होता है इन तीनों में, रिपीटेशन इज लॉस्ट। उसके अलावा एंटीरियर सुपीरियर टू द ब्रोकास इज ट्रांसकॉर्टिकल मोटर, पोस्टीरियर इंफीरियर टू द वर्नेक्स द सेंसरी एरिया इज द ट्रांसकॉर्टिकल सेंसरी एरिया। लेकिन पढ़ो, ये चीजें जो है एग्जाम वाली चीजें हैं जो जरूरी है, चीजें काम नहीं चलेगा। इसी अब इंडिविजुअल कैलेंडर्स है, साथ में सब कुछ पता है। ये इसके लीजन्स, ऑप्टिक नर्व पाथवे पता होने चाहिए, प्लेन नर्व्स आगे क्या बहुत ज्यादा लंबा हो जाएगा। एक और बहुत इंपॉर्टेंट है, रूटीनली आपको होता होगा, लाइट रिफ्लेक्स एंड अकोमोडेशन रिफ्लेक्स, इनके पाथवेज क्या हैं? लाइट रिफ्लेक्स रोजाना करते हो? कॉर्टिकल ब्लाइंडनेस में लाइट रिफ्लेक्स प्रेजेंट है एब्सेंट? कॉर्टिकल ब्लाइंडनेस में लाइट रिफ्लेक्स प्रेजेंट और एब्सेंट? भाई हाँ जी, नहीं बताओगे यार तुम? लाइट रिफ्लेक्स का पाथवे कहां से टर्मिनेट हो जाता है? लेटरल जेनिकुलेट बॉडी, उसके बाद एडिंगर वेस्ट्रल न्यूक्लियस, दोनों साइड में भेजता है वो, इसलिए डायरेक्टर कंसेंसुअल आते हैं। और एकोमोडेशन रिफ्लेक्स क्या है? एकोमोडेशन इज नियर विजन वाला, क्या कहां से आता है वो? अरे नाम पढ़ा होगा यार, एरगैल रॉबर्टसन प्यूपिल, नहीं पढ़े हो? चलो अब आगे चलते हैं। आई मूवमेंट्स, अब तुम्हें सेकेंड्स ऑफ परसूट्स की बात क्या करेंगे फिर? फेशियल नर्व एग्जामिन करो, वेस्टिबुलर करो, 9th 10th एंड 11th 12th। मोटर में सेंसरी दोनों तरह टेस्ट करने, पुस्टर कॉलम, स्पाइनोथैलेमिक एंड कॉर्टिकल। दीज आर वेरियस सेंसरी लॉस हैं, आपको देख रहे हो। पहले वाला कहां का है सेंसरी लॉस? फर्स्ट, सेकंड है क्रॉस्ड, ये ब्रेन स्टेम का है। थर्ड कॉर्ड का है, और जो फोर्थ है ऊपर वाला, उधर वाला किसका है? फोर्थ सेंसरी लॉस, दिस सस्पेंडेड सेंसरी लॉस, सिरिंगोमाइलिया। This is neuropathic. These are nerves again, reflexes, and after all reflexes, we make again a provisional syndromic diagnosis, then again a differential diagnosis, then a plan of investigations as per diagnosis, and then उसके बाद जो चीजें आती हैं, एक बहुत चीज जरूरी है, आपको पूछा जा सकता है, मसल के टेस्टिंग में क्या करोगे? मसल के लिए टेस्टिंग ईएमजी है। न्यूरोमस्कुलर जंक्शन के लिए क्या करते हो? न्यूरोमस्कुलर जंक्शन के लिए दो टेस्ट, रिपीटेड नर्व स्टिमुलेशन और दूसरा सिंगल फाइबर ईएमजी। पूछा जा सकता है एग्जाम में, नाम तो पता होना ही चाहिए। सिंगल फाइबर ईएमजी में क्या टेस्ट करते हैं? जिटर। एंड नर्व्स में यस, एलसीवी, मोटर, सेंसरी, एफ वेव, एच रिफ्लेक्स। आपको कम से कम नाम पता होने चाहिए, और एटलीस्ट क्या टेस्ट करते हैं से ये पता होना चाहिए। कॉर्ड में एसएससीपी, ब्रेन स्टेम, ट्रेनर्स में वीईपी, ब्लिंक रिफ्लेक्स, बीएपी, बेरा, ब्रेन में ईजी, एमईजी। व्हाट इज एमईजी आइडिया? एमईजी नहीं, बीएपी, बेरा। देन अगेन फॉर ब्रेन P300, MLR, LLR, बहुत सारे टेस्ट अवेलेबल है। तो पर्पस ये था कि स्टिल सब कुछ करने के बाद में बहुत सारी चीजें अनडायग्नोज रह जाती हैं, और ट्रीटमेंट में ट्रीट द ट्रीटेबल इन प्रेफरेंशियल मैनर विद एविडेंस बेस्ड प्रोटोकॉल। न्यूरल टिश्यू इज वेरी सेंसिटिव, टाइम इज अ ब्रेक। थैंक यू to discuss it.
Thank you, sir, for such a stimulating speech. Never thought a neurological case approach could be explained in a simple yet effective way. It would surely end my conflicts with neurology for time to come. I would request Dr. Saurabh Singhal, sir, to express his gratitude to the chairperson and speakers of this talk. I would also request Arun sir to pick up a lucky draw for the event.
भूख लग रही है भाई
Dr. Parth Patel. Dr. Parth Patel. सारा लग गया ठाकुर वाले लेके आए क्या? ये क्या फाइल सर? क्या बात है सारा का सारा सारे ठाकुर वाले Windows to the speakers and the chairpersons.
प्रेजेंटेशन चलाने और भी चलाने हैं अभी सबकी वो टॉप में ठीक है
We will proceed to the last talk of the session. This is the respiratory talk. And I would like to invite our chairpersons first. The first chairperson is Dr. Amit Agarwal sir, a very famous name in the respiratory medicine. He has done MBBS from LLRI Medical College 2001 and PG from GSM Kanpur in 2005. And he is a consultant chest physician, bronchoscopist and critical care specialist. He is having his own state-of-art respiratory center equipped with world-class modern instruments required for the management of any type of respiratory patient. He has received prestigious Srimati Gurjeshwari Tiwari Memorial Award for Best Organizing Secretary during the 2012-13 from IMA UP headquarters. Presently, he is Honorary Secretary of Indian Society of Critical Care Medicine, Meerut branch. Welcome, sir. Our next chairperson is Dr. Ima Chaudhary ma'am. Very renowned face in Subharti and a tireless worker. Ma'am has done DNB Respiratory Medicine from Impress Apollo Hospital, New Delhi, and fellowship in critical care medicine. She has 12 years experience in teaching and currently is the head of Department of Respiratory Medicine Department, Subharti Medical College. I would like to call Ima Chaudhary ma'am to introduce our next speaker, Dr. Wilhelm sir.
Thank you, sir. Congratulations to Subharti, especially the medicine team for doing a great job. I had been thinking and thinking only I could not do it till now. Congratulations, Saurabh, sir. And it's really my pleasure. Thank you from my heart for inviting me as a chairperson. It's been a privilege to invite Dr. Gautam Tomar, sir, a stalwart in our field, and especially of this area. And with due regards to Mukti ma'am, I would now welcome Gautam sir to please take his talk. A very brief, although it's a large chunk of his history, I would say, and his cadres that he has had, but a few things of his achievements. He is a graduate from SN Medical College, Agra, and then his MD from GSVM Medical College, Kanpur. He has been awarded prestigious fellowship from American College of Chest Physician. He is a diploma in European adult respiratory medicine. He's a pioneer in EBUS, and I've met him. In fact, I've learned from him through the years. I've heard him in all the famous talks. He's a pioneer in EBUS. His field of interests are interventional pulmonology, ILDs, ABPA, and MDRTP. He's having his own advanced respiratory lab and lung function test, equipped with all the modern things. He has been awarded with a lot of things. Excellence in Healthcare Award by Dainik Chaplain in Lucknow year 2019. Member of National Guidelines for Medical Thoracoscopy year 2022. Honored by Malaysian Health Ministry for EBUS training, and is the past president of Indian Medical Association, Meerut branch. Welcome you, sir.
Hello. Hello. Thank you, Chairperson. Thank you, Dr. Iman. Thank you, Dr. Amit. And
We will have lunch after this last talk, so please be patient. I request to all PGs here, please be patient. This is the last talk of the day. We are running late slightly, so we will have lunch after this talk.
thank you, Dr. Saurabh, for inviting me. And I want to congratulate the medicine department for organizing such type of CME. So my topic is to discuss COPD, the chronic obstructive pulmonary disease. We all know what about the COPD and bronchial asthma from even MBBS days, but as is the PG CME. So I will discuss a little bit how we can differentiate, how we can make diagnosis of COPD, what are the salient features of COPD, and how the combination therapies are available nowadays. So I will discuss in next 20-25 minutes. To start, in 1990, WHO has done a study, and he found that COPD was one of the topmost 10 top killers worldwide. And they expected at that time in 1990 that in 2030 it will be the third top 10 killers COPD. But you have seen in this slide in 2012 Lancet published, and they found that in 2010 it already achieved this status in 2010 what WHO had expected it would be in 2030. The reason is that we all know the pollution, environmental pollution, smoking habits, and all other things I will discuss, it is increasing. Should we be worried about chronic obstructive disease in India also? Yes, definitely. The prevalence of COPD in India in 2090 it was 28.1 million, while in 2016 it rose up to 55 million. And it is the second leading cause of death and disability adjusted life in years in India. And you can see 120 million tobacco smokers are existing in India. More than 60% of population lives in homes where biomass fuel is still used, and 50 to 76% of households use mosquito repellents for protection of mosquitoes, and more than 35 million people who suffers from chronic bronchitis due to the ambient air pollution. We all know about the COPD, how it occurs. The major culprit is smoking, either in the form of cigarette, either in the form of BD and hookahs and all these type of smoking habits. And it is important to know that mosquito coil, single mosquito coil give at least equal to 100 cigarette particulate 2.5 particles for the person who is exposed to it, and approximately 51 equal to formaldehyde it releases equal to 50 cigarettes per day. So it's significant. We have to know that this mosquito repellent coils are quite toxic and can cause not only COPD, it can lead to even lung cancers. We all know the construction work, dust, environment, can lead to destruction of alveolar septals and lead to chronic obstructive pulmonary disease. Different occupation like patients, those are the person who are working in the industries, the policemen standing at this traffic chorhayas, and all these different type of poultry works, farmers, they are using different types of insecticide sprays that can all lead to the COPD. Why does COPD not receive its due attention? It may be the few reasons. You can agree with me that COPD does not kill as suddenly and unexpectedly as myocardial infection. So the cardiologist, the first lecture you have heard Dr. Rajiv Agrawal, the cardiologist has done great job by creating the fear in the community that cardiac events are more dangerous than the lung attacks. But you will be surprised if any patient admitted in the ICU with lung attack or COPD acute exacerbation, and he went on mechanical ventilation, the survival of COPD attack is quite, you can say, it's very difficult to save that patient in comparison to those patients who come with MI or acute heart angina and all these things in ICUs. Second reason maybe does not affect children like asthma does, and more frequent in the lower socio-medical status classes. It is related to smoking habits, it is own fault, and clinically relevant only at the end of the productive periods of one's life, like around 50, 60 years of age. And it is poorly responsive to treatment in comparison to like other disease, like in bronchial asthma and other disease. So COPD remain neglected part. We seems to be slipping because 60% to 65% reduction in death rates due to coronary heart disease and stroke in the previous decade, and approximately 150% increase in death rates due to the COPD. You can see in the slide that since 2008 and expected to be 2030, the COPD's graph is rapidly rising, while other diseases like HIV, tuberculosis, malaria, the graph, and even cardiac CAD disease are going down, except diabetes. Diabetes is still on the rising trend, but COPD will be the most top 10 killers in next few years. So when we see we all should know what is the COPD definition by GOLD guidelines. It was published first time in 2000. They have given this definition: a disease state characterized by airflow limitation that is not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases like pollution. In 2011, GOLD again revised this definition, and they added that it's not only untreatable disease, it's a treatable disease and even preventable disease. And one thing GOLD guidelines added that this exacerbations and comorbidities are very important to treat in COPD. We should know what are the exacerbations and how the comorbidities like CAD and other diabetes and obstructive sleep apnea, GERD, etc. can lead, osteoporosis can lead to aggravation of this COPDs. In 2013, COPD in GOLD guideline added spirometry to confirm this disease, because the all breathlessness and all cough is not due to the COPD. It may be due to bronchial asthma, it may be due to the interstitial lung disease, it may be due to the congestive heart failure. So we have to confirm COPD by the method of spirometry. And they mentioned that the post-bronchodilator FeV1 upon FVC ratio should be 0.70, that confirms the diagnosis of COPD. And in latest, in 2023, again, GOLD has revised guidelines, and they said the chronic obstructive disease is a heterogeneous group of disease and characterized by chronic symptoms like cough, dyspnea, sputum production, and exacerbations due to the abnormality not only airways but also in the alveoli like emphysematous, and causes persistent, often progressive airflow inflammation. So just to give an idea, the causes of COPD we all know, basically cigarette smoking, air pollution, occupational exposure, infections, even early childhood infections can lead to later on life development of COPD, alpha antitrypsin deficiency, low intake of vitamin A, C, and E, and atopy and airway hyperresponsiveness that can lead to ACOS. Combined, we can say there's the combination of like bronchial asthma and COPD, the ACOS syndrome. Now it's ACOS, and low birth weight and even tuberculosis-like disease can lead to the COPD. You can see in the slide the healthy lung and COPD lungs, how it looks. The symptoms are same, like started with smoker's cough. Most of the times it happens in the most of the age group of 30, more than 35 years of age, around 40 years of age, the smoker starts coughing. And it mostly the hacking cough or early morning sputum they produce. This is called smoker's cough, chronic bronchitis. And shortness of breath, excessive sputum production, and feeling like you can't breathe when you climb the stairs and can't take deep breaths, and wheezing sounds can occur in these type of patients. And symptoms like when it's hard to breathe, it's hard to do anything. People with COPD avoid activities they usually used to do more easily, limit activities to accommodate shortness of breath, and other symptoms. Sometimes activities include like they take elevators instead of stairs, they park close to the nearby building and avoid walking, and avoid shopping or other similar day-to-day tasks, and stay home rather than go out to meet the friends. And the symptoms of COPD are usually worse in the morning. This is published in 2009 in a survey of 800 COPD patients in Europe and USA. The morning was the worst time of the day of COPD symptoms, especially for patients with severe COPD. And morning activities most affected by COPD were like walking up and down stairs, putting on shoes and socks, making the bed, dressing, showering, bathing, and drying. The majority of patients were not taking their medications in time for it or exerts its optimal effect. That is the reason. And how this dyspnea leads to a spiral downhill of this disease. You can see that when dyspnea with activities occurs, the patients become more sedentary, avoid dyspnea producing activities like exercise, walking, and the deconditioning of these muscles can lead to, again, the worsening of the patient's overall personality, or we can say the lungs functions. It is important to know the symptoms are not typical of COPD. Like if COPD patients producing blood, that can be due to any other reason, maybe the high chance the smokers having lung malignancies. Seasonal exacerbations favor most of the time bronchial asthma. An excellent response to bronchodilator and steroids with definite symptom-free interval again can lead to the diagnosis of bronchial asthma, not COPD. And continuous expectoration of purulent sputum may be due to the bronchiectasis and other diseases like cystic fibrosis or lung abscess. The breathlessness without productive cough or wheezing may be due to the interstitial lung disease or lung fibrosis. We all know the signs of COPD: patient having large barrel-shaped chest, prominent accessory muscles in the neck, prolonged expiration with wheezing, cyanosis at rest in advanced stage, and tendency to lean forward over its support to assist breathing. The investigation list: in routine, we have to do spirometry first thing, and other routine blood test, even chest X-ray to rule out other diseases like lung malignancy, bronchiectasis, even look for the cardiac size. In moderate COPD, we can do the DLCO test and other lung volumes, ECG, and in patient is if we have planned for any therapy for COPD, we can do HRCT chest to see if we can do the lung volume reduction surgeries and other things. And even in COPD patient, sleep study is also recommended, that can be having as a comorbidity and worsening the COPD. The spirometry parameters we all know. For bronchial asthma, in pre-bronchodilator, FE1 upon FEC ratio should be 75, and in COPD patient post-bronchodilator, if it is less than 70%, then it confirms. The missing link in diagnosis today is like, even simple PEFR we don't do, most of the practice, and the simple test is spirometry. Like, we cannot confirm or label a patient hypertensive without getting BP measuring. And without ECG measuring test, we can't say that patient is having MI or other illness. Then the same way, without testing with spirometry, we can't label the patient of COPD or bronchial asthma or interstitial lung disease. Why do we want to do spirometry in COPD? First, to make diagnosis, an assessment of severity of the disease, and following the progression of the disease. And third, spirometry may detect the presence of mild airway obstruction 5 to 10 years before the disease start to cause symptoms. So it's the very first test you have to perform in a smoker if patient is having more than 35 years of age or more than 40 years of age. The differential diagnosis: CHF, congestive heart failure, bronchiectasis, obliterative bronchiolitis, chronic asthma, tuberculosis, and diffuse bronchiolitis should we keep in mind when we make a diagnosis of a patient of COPD. The patients with COPD shows an accelerated annual decline in FEV1, often greater than 50 ml per year in compared to normal decline, that is 18 ml per year. So it's a very fast decline in COPD patient. So every consultation, when we see a patient of COPD, we should ask to avoid smoking or stop smoking. The mechanism of, we all know, it's due to the mucus hypersecretion, small airway obstruction due to chronic inflammation, and the imbalance between the protease and anti-protease mechanism, imbalance, oxidative stress, and the remodeling of the pulmonary circulation. And the culprit cells, basically the macrophages and the neutrophils, they release neutrophilic elastase by the stimulation of the environmental dust particles or even smoking, and that lead to destruction of alveolar receptors and leading to the emphysema, or directly they stimulate the nerve endings, they can increase the mucus hypersecretions. So this is the reason, this is the disease of not only inflammation, but is also due to the loss of elasticity or the collapsing of the airways. We call it emphysema. So the outcome of inflammation is the mucus hypersecretion, fibrosis, alveolar destruction, pulmonary hypertension, and muscle pathology, and they all lead to different type of combination of symptoms like chronic cough, airway obstruction, hyperinflation, hypoxia, and hypercapnia, and right-sided heart failure and respiratory and muscle weakness. The goal of COPD management is to relieve symptoms, improve exercise tolerance, and improve health status, and reduce the risk of progression and to prevent exacerbation and reduce mortality. So the gold guidelines have given that first we have to look symptoms, risk factors, and we should do spirometry, and we can assess these on the basis of spirometry, the grading of the severity, like grade 1, grade 2, grade 3, grade 4, and accordingly we can give pharmacotherapy on the basis of severity. Non-pharmacotherapy like pulmonary rehabilitation, NIV support, BiPAP supports, oxygen therapy, and all these things we can do as a non-pharmacotherapy. But in pharmacotherapy, the basic crux of COPD is to treat with inflammation with the help of antimuscarinics, and the bronchodilators is the basic treatment to treat the COPD patients. Like therapeutic options, we are having first, most important is the smoking cessation and reduction of risk factor, which we have discussed, like if patient is using biomass fuel at home, or patient is working at a dusty atmosphere, so we have to change the occupation of that patient. And the beta agonists, we are having two types, short acting and long acting. Anticholinergics, we are having short acting and long actings. We have combination of different drugs. I will discuss methyl xanthines like gerifalin group, and inhaled corticosteroids and systemic corticosteroid and phosphodiesterase 4 inhibitors in our basket to treat this disease. This is the latest guidelines. I will show this how it changes from 2022 to latest change in this gold guidelines is this. First, we have to confirm this with spirometry. If it is less than 0.7, then we have to assess airfield obstruction from grade 1 to grade 2, 3, 4. If FEV1 is more than 80, grade 1. If grade 2 is 50 to 80%, and if it is 30 to 50%, it's grade 3, and grade 4 it is if it is less than 30%. So we have to do the airflow obstruction as assessment, and on the basis of symptoms, like if patient is having more than 2 exacerbations or more than one leading to hospitalization, we can say it's a severe form of exacerbation. And if patient is having 0 or 1 or moderate exacerbation not leading to hospitalization, we can say it's a mild form. And previously it was A, B, C, D groups of COPD disease, but now the latest is a B, and a E. And on the basis of like CAT scoring, MMRC scaling, we can keep A if it is less than 10 in CAT scoring and MMR score is around 1. If it is more than MMRC scale or 2 or CAT score more than 10, we can keep in the group B. So it's important to know what is the combined assessment system, how we can use these systems like CAT score. What is CAT score? Is all symptom. If it is less than 10, we can keep in that stage 1. A, if it's more than 10, we can keep in the group of B. And this is the CAT score you can download from the Google, that what is the CAT scoring system. And what is the MMRC's breadth scale? I think most of PGs should know what is the 0, 1, 2, 3, 4 scaling system. If it is up to 1, we can keep COPD in the group A. If it is more than 1, we can keep in the group B. And both we can use CAT scoring system, MMRC scaling system, but CAT score system can score prefer over MMRC, and score range more than 10 is significant to keep this in moderate to severe form of COPD. Again, the mechanism of treatment, or this by the help of this ABCD differentiation, we can keep that, like if patient is having a group A, we can give only bronchodilators. When long-acting bronchodilators are preferred. If patient is in group B, we can give combination of long-acting beta agonist and long-acting anti-muscarinic agents. And if patient is in group C, in group E, which was previously C and D, now it is group E, we can give combination of both LABA and LAMA. And along with patient is having high eosinophil counts, we can give steroids, inhaled corticosteroids. If patient is having dyspnea and exacerbation, which approach we should follow? If patient is having both, then exacerbation limb we have to follow, like we have to add LAMA and LAMA both. And if your eosinophil counts is more than 300, we can add inhaled corticosteroid. And all 3 inhalers are present in the single combination therapy nowadays. So the compliance is better and the overall response or management part is better when we give combination therapy. When we should give inhaled corticosteroids? Previously, inhaled corticosteroids were contraindicated in COPD, and it was meant for only bronchial asthma patients. But in TORCH study, that was published in 2006 in Lancet, they studied that salmeterol and the inhaled corticosteroid fluticasone, when given, the exacerbation reduces and they help very much. So the same TORCH study and further studies and different other studies showed that if eosinophil counts is high, if it's more than 300 ml, patient have frequent exacerbations, then we can use inhaled corticosteroid. The against use is patient where we should not use inhaled corticosteroid, like if patient is having high risk of tuberculosis or relapse, or patients having chances of pneumonia, or eosinophil counts are less than 100. So bronchodilators, the central of management of symptomatic COPD is the bronchodilators. And the classes of bronchodilators are beta-2 agonist, muscarinic antagonist, and methylxanthines, theophylline. And the long-acting bronchodilators versus short-acting, long-acting are preferred more than the short-acting. We all know this slide, how the smooth muscle contraction influenced by more than one nerve systems, like this, the nodose ganglion, they can, if stimulation occurs at this level, the stimulation travels through the vagus nerve, and there is acetylcholine release at the presynaptic fibers, and along after this post-synaptic ganglion, the acetylcholine release at the smooth muscles, and again the other way of traveling this stimulation is by C fibers and the A fibers that are present in the bronchial tree. They can directly stimulate by the noxious particles of gases or smoking, and they can release these type of acetylcholine directly. And the bronchodilator, what happened when we give bronchodilator? They improve the respiratory muscle function by reducing hyperinflation, by relaxing the smooth muscles and increasing the mucociliary clearance. This is the activity how this bronchodilator works. The second part is important. The main crux of COPD management is the anti-muscarinic bronchodilators. That is, they inhibit the acetylcholine, like the ipratropine bromide, we always used to give it as nebulization form. The ipratropine bromide, we all know that there is a 5 type of muscarinic receptors in the airways, M1 to M5. But most important anti-muscarinic receptors are the M1, and M2 and M3. Here M1 is on the parasympathetic ganglion. It stimulates the acetylcholine release, while the M2 receptor that is on the post-ganglionic nerve ending, this having the auto-regulation or it inhibits the release of acetylcholine. While the M3 receptors again is on the smooth muscles, they again release the acetylcholine. Here this slide is important because nowadays ipratropine bromide, which was available, now other anti-muscarinic like tiotropium bromide and glycopyrronium anticholinergic drugs are available. So how they differ? If we give ipratropine bromide, this drug acts on all 3 receptors like M1, M2 and M3 receptors. So it not only inhibits the activity of M1, it also inhibits the activity of M2. That is the autoregulatory or automatic inhibits the release of acetylcholine. While tiotropium and glycopyrronium, they act more on the M3 receptors and they don't act, or they very early get release from the M2 receptors. So there is only one way action. There is or you can say combined action from naturally from M2 plus by the inhibition of the M1 and M3 receptors. So combination therapy, which is approved by FDA, there's a long list, but the important thing, the combination of which we have already discussed, ICS and LABA, that is the TORCH study. This is the newer combination, which is the latest combination. The last few years we are having 2-3 years. This combination where long-acting beta agonist, long-acting anti-muscarinic agents, and inhaled corticosteroids are combined in the same inhaler, and they have different type of mechanism of action, and they give the, you can say, synergistic effect when we combine anti-inflammation, bronchodilation, and the anticholinergic effect. This is the primus study. I'm not going to discuss detail, but definitely to conclude is this. The prompt inhibition of triple therapy decreases the risk of future exacerbations, and timely consideration of triple therapy after a single severe exacerbation or 2 moderate exacerbations could decrease overall potential morbidity and lessens the economic burden of COPD. The triple drug therapy, the other studies I am not going to discuss, but here is one slide that is important. When we use multiple inhalers in comparison to single inhalers, the adherence is less than 34% with multiple inhalers, and the discontinuation of therapy is more than 44%. So it's better to combine all 3 inhalers in a single inhaler so that we can have a good results in comparison to multiple inhalers. So the advantage of triple therapy I have already mentioned. Word about the COPD exacerbation. This slide is important, as previously I have showed that every exacerbation give little bit decrement in the lung functions. So we have to avoid this exacerbation by proper therapies, which I have discussed in the combination therapy. This is the slide showing every exacerbation reduces the life of a patient. So we have to keep in mind, we have to put every effort to stop this exacerbation and educate the patient how we have to treat, how to take the inhalers. So this is my last slide, and there is a mounting evidence from the clinical trials and the meta-analysis that dual combination LABA-LAMA is the highest ranking therapy for the patients, irrespective of the history of exacerbations. Inhaled corticosteroids can be useful add-on in specific set of patients, and recently several trials have evaluated efficacy and safety of fixed dose triple therapy ICS, LAMA, LABA, and clinical evidence from meta-analysis and real-world studies suggest that single inhaler therapy has advantage over the dual combination as well as over multi-inhalation therapy in terms of exacerbations and mortality. So thank you so much. I think I've waited you for lunch. Thank you. Thank you for patient hearing.
That was indeed a very informative talk, sir. I would now request Dr. Saurabh Singhal, sir, to thank the chairperson and the speaker for their kind presence.
Thank you, sir.
Dr. Subharti Sharma, Medicine. आवाज नहीं फाइनल ईयर इंटर इंजीनियरिंग
अरबाज इलाही,
डॉक्टर मुशारफ आप बड़े हैं डॉक्टर अरमान एसआरटी डॉक्टर सुनील पाल
अभी स्टार्ट कर दो पूरा कोई उसी पर हो ठीक
क्या हुआ?
क्विज के लिए आप क्विज का सर लंच अनाउंस करना है नहीं टुगेदर कमर 3 करेंगे लंच सबने करना है
10 minutes, all of which
all quiz teams together in 10 minutes.
शुभ्या तो मुझे 10 मिनट पहले एंड से 10 मिनट पहले मैसेज कर
Hope everybody has taken the lunch.
I hope everyone has had their lunch. I would request all the teams that have been participating in the PG quiz contest to gather onto the stage in the next 10 minutes.
चेयर कहाँ से लाएंगे?